the Joint Standing Committee on Health and Human Services. We'll be hearing 7 or 8 bills this afternoon. We'll be doing it a little bit out of order because we've had a request from one of our colleagues to go soon after 2 as possible. So we'll start in the order in which they're published and go LD 112, 1197, and then see what time it is. If it's before 2, we'll then proceed to LD 949 and keep going down the list until we get to 2 o'clock, at which point we'll slot our colleague in and then go back to 1139. So it's a little confusing, but Carrie will keep us on track. So welcome everybody. And before we do introductions, I just want to remind folks that you can also watch on our YouTube channel. If you go to maine.legislature.gov and look up under HHS, Health and Human Services, you should be able to find the YouTube channel where this is being broadcast live and in color and with audio. We'll be taking testimony today related to the bills that we'll be hearing. Everybody other than the presenter basically gets 3 minutes. We have clock watchers and they'll give you a reminder 30 seconds to go. And we'll try and keep on some sort of reasonable schedule that way. Then the committee members will be able to ask questions of whoever's been presenting, and we'll move on to the next when we're all done. So that's the current plan. We anticipate, if it's like any of our other sessions, that there will be computer glitches. We won't be able to hear somebody. People are going to drop out. So just bear with us and we'll work through it and get along. And so don't be surprised. Just try and be patient with us while we sort things out. So let's go around the proverbial horseshoe, which doesn't technically, I suppose it's still there, but just not occupied. Let's start with Representative Zager.
Good afternoon, everyone. My name is Sam Zager, honored to represent District 41 in Portland.
So I'm sorry, Representative Lemelin.
Thank you, Senator. My name is Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
Thank you. Representative Stover.
Good afternoon. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, West Port Island, and part of South Bristol.
And Senator Baldacci.
Thank you. I'm Joe Baldacci. I represent Senate District 9, which is the city of Bangor and the town of Herman. Thank you.
Representative Perry.
Good afternoon. I'm Ann Carey. I represent House District 140, which includes the towns of Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Thank you. And Representative Griffin.
Good afternoon. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescate.
Okay. And Representative Connor.
Thank you, Mr. Chair. Good afternoon, everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
And Representative Craven.
Thank you, Mr. Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan.
Good afternoon. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Javner.
Good afternoon. I'm Representative Kathy Javner, and I represent House District 141, which is located in Penobscot in Washington County.
Senator Moore.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Thank you, Mr. Chair. Welcome to all who have joined us here today. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, all of Elliott, and parts of South Berwick and Kittery.
And I'm Ned Claxton. I represent Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. So we also are ably assisted and able to do our work because we have some great staff. And I see Ms. Broom with us.
Hi, I'm Anna Broom. I'm one of the legislative analysts for the Health and Human Services Committee, and I work for the Nonpartisan Office of Policy and Legal Analysis.
And Ms. Withy.
Good afternoon. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
Okay, are there any particular details to take care of before we get to LD 1112? I don't see any, so we'll go ahead and start with the resolve to classify employee health insurance as a fixed cost for main care reimbursement in nursing homes. And I see that Senator Timberlake has just joined us. Welcome, Senator.
Good afternoon. Senator, how are you doing today?
I'm doing all right, thank you.
Well, I thank you for letting me go here, and we'll get going. I'll even try to be under by 3 minutes. Senator Claxton, Representative Mayor, and distinguished members of the Joint Standing Committee on Health and Human Services. I am Jeff Timberlake. I represent Senate District 22, which includes the towns of Durham, Greene, Leeds, Lisbon, Litchfield, Sabattis, Turner, Wales, and Wayne. It is my pleasure to be here to represent LD 1112, the resolve to classify employee health insurance as a fixed cost for the main care reimbursement in nursing homes. Those of you who have sat on this committee last session may recall I stood before you just over 2 years ago and presented this same bill, LD 1126, from the 129th legislation. The measure was carried over and ultimately died when the session ended early because of the pandemic. To provide a little background, back in December of 2013, the Bipartisan Commission of Study of Long-Term Care Facilities released a series of recommendations, several of which were implemented. One recommendation by the commission that was not yet been put in place is to make health insurance a fixed cost in nursing home facilities. Generally do offer health insurance to employees, but this has become extremely difficult because of the rising premiums and the cost. We must keep in mind that now more than ever, with Maine population being of the oldest in the nation, nursing homes need to be able to attract and retain the best employees. And this can be done with competing wages and benefits. 2 years ago, the committee reported out the same proposal as ought to pass as amended. It is my hope this panel will again send this measure to the chamber with a report to pass. We need to show our support for nursing home facilities and the hardworking staff who take care of our friends, neighbors, and family members. I appreciate your attention and will try to answer any of your questions. However, folks will be testifying after me that are much better versed than I am in explaining the different aspects of the main care rates and reimbursement. And they have a better handle on the intricacies of Chapter 101 of the Main Care Benefits Manual and a piece of this resolve proposed to amend. I thank you for your time and consideration and will gladly try to answer any questions, but I feel this is a very important issue. It's something that nursing homes are struggling with, and any of you that's listened or been around any nursing homes understand that this is a problem right now, and it's a problem that needs to be addressed to keep people working here and offer them benefits so they stay working there. So I'll try to do my best, but thank you. Senator.
Thank you. Thank you, Senator Timberlake. Are there any questions of the senator? I don't see any. I guess they've taken you at your word that there's people more comfortable with this data than you. So thank you for being there to present it.
Thank you. You guys have a good afternoon now.
You too. Speaking in support of this bill, we'll join first by Rick Erb and then Wanda Pelkey. So Rick.
Good afternoon, Senator Claxton, Representative Meyer, members of the committee. My name is Rick Erb and I'm with Maine Healthcare Association. We represent nursing homes and assisted living facilities. I want to thank Senator Timberlake for submitting the bill. In a survey of our members' facilities last year, 78 out of 79 respondents said that they provide some form of health insurance for their employees. I would say that over the years, a key difference between long-term care employers and competing industries has been the ability to offer this type of benefit to employees. That is becoming more difficult, though, as premium costs increase. In the same survey, 53% said that they had to make changes in coverage because of the expense. The average facility pays for 73% of employee coverage and 44% of family coverage. In 2020, the average employee cost was $740 per month, which is 18% higher than it had been 2 years before. The average family coverage was over $2,100 per month, which is 25% higher than 2 years prior. Competition for employees makes coverage more important than ever. There has been a distinct and important focus on wages in Maine over the past few years, resulted in last year seeing a 4.3% increase. That was 2020, prior to COVID-19. I can tell you they've gone up much more rapidly since then. But wages aren't the only determining factor in long-term care employment. This bill recommends amending the Maine Care Principles of Reimbursement to make health insurance a fixed cost. Making it a fixed cost, like property taxes and workers' compensation insurance, would ensure providers are wholly reimbursed for this expense. LD 1112 clearly makes a statement for healthcare employees. Insurance is a priority. I would also remind the committee that the Maine Care portion of the facility revenues is matched by 2-to-1 in federal funds. If, for instance, 75% of the facility are Maine Care, then 75% of the insurance costs will be matched 2-to-1. It's even higher now with the temporary rate increases. It does seem like a long time ago when the Long-Term Care Study Commission came out with its recommendations, as Senator Timberlake mentioned. Other recommendations have been put into law. This one has not. Subsequent long-term care study work in 2019 continued to place the emphasis on the importance of insurance for employee recruitment and retention. This committee has historically supported this, but it hasn't been funded yet. It's my hope that if you support this again, perhaps we can leverage federal relief money coming into the state to make it a reality. Thank you for the opportunity to comment.
And thank you, Mr. Erb. Are there any questions, Mr. Erb? Is there some way to get a sense of what the impact is per bed or per 100 or something like that for this change in terms of accounting?
I'm sure there is. And actually, when Wanda Pelkey speaks, she is a CFO. She's somebody I would be working with in advance of the work session to see what we can do for that.
Okay.
I'm sure we can. We have great data.
Thank you. Any other questions for Mr. Erb? I don't see any, so we'll welcome Ms. Pelkey, invite her to unmute herself and join us.
Thank you. Good afternoon.
Good afternoon to you.
Senator Claxton, Representative Meyer, and members of the committee. My name is Wanda Pelkey, and I am the board chair for Maine Healthcare Association, as well as being the CFO for First Atlantic Healthcare. Our company has 20 nursing facilities and res care facilities throughout Maine. We care for about 1,500 residents across our state. I'm testifying in support of LD 1112, and I also thank Senator Timberlake, Claxton, and Moore, and Representative Perry for co-sponsoring this bill. Now, several years ago, I held a health insurance renewal meeting where I was proud to offer a health insurance option that was $10 a week cost to our employees for single coverage. And I was pretty proud of myself because I thought that that was a pretty terrific deal. But after the meeting, a CNA approached me and she quickly shifted my point of view. And she said bluntly to me, she said, the $10 a week option stinks. She said, the deductible is $6,400 a year, and I can't afford that care or buy coverage for my kids. That reality was painful for me to hear, but unfortunately, we could not afford to do better. And so I asked, how could this bill help? I'd answer that it would help me keep insurance costs lower for my staff. And it would limit the need for me to charge more when we have difficult insurance renewals. By categorizing health insurance premiums as a fixed cost, quote unquote, it ensures that those costs would be paid ratably by the Maine Care program. We all know that health insurance costs are expensive and they rise rapidly. Regularly, plan renewals cause our premiums to increase by 10 to 20% a year. Shopping the business with other vendors is seldom helpful. Sometimes they don't even bother to quote. I know our company isn't alone, and these increases far outpace cost of living increases that are provided by MaineCare annually. So to balance our budgets, we often charge more to our staff. This has created an awful cycle of unaffordable premiums, higher deductibles. Some employees then drop coverage. Those that remain are generally the heavier users on their plan, and it leads to premium price hikes the next year. So on face, it just seems wrong that our healthcare staff can't afford their own healthcare, even though the insurance we offer is deemed affordable by ACA definition. I believe this bill can help by providing a reliable matching MaineCare payment to our health insurance costs, helps us provide good benefits at affordable rates. It helps too that these payments are heavily supported by federal dollars, as Rick Erb said in his testimony. If we can lower employee out-of-pocket costs, it also helps recruit sorely needed direct care workers and really gives them a reason to stay. I feel that it's a step in the right direction. In terms of the question that you asked about the cost, generally every 2 years when nursing facilities go through a rebasing, those increased costs do get picked up in a rebasing moment. Unfortunately, those in-between years when we are required to pick up the costs and the burden of increasing healthcare coverage, the benefits of aligning our payments with those costs are not a perfect match. And then it requires us to make these tough decisions. If this bill was enacted now, we would not have this gap in a period of time while we wait for rebasing to happen. Happy to take any questions that you have.
Thank you for answering that question.
welcome.
Are there any other questions of Ms. Pelkey? And so by getting rebased every 2 years, you have to absorb the 10% rise in health insurance costs in the intervening years, basically.
That is true. And even with the rebasing, sometimes there are upper payment limits that limit our ability to get full cost reimbursed.
Okay. I don't see any other questions, so thank you and Mr. Erb for being here and Senator Timberlake for presenting this. There's obviously some support on the committee and we'll look to spend some time with it in the next work session.
Thank you.
Thank you all. Are there any questions for that work session that we want to direct to our analyst? So I just want to make sure that the bill we're considering is the same one we passed as amended last time. That's my only question. Any other concerns, directions? So that'll conclude the public hearing work on LD 1112. And now we'll go to LD 1197. And Representative Craven is here to present that.
Thank you, Mr. Chair. So Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. My name is Margaret Craven and I represent House District 59, which is part of Lewiston. Reimbursement to the nursing facilities for bed day holds during hospitalizations and therapeutic leaves of absence before the Joint Standing Committee on Health and Human Services. So you're all very familiar with this issue after going through the budget and other conversations that we've had. LD 1197 resolved to require continued MaineCare reimbursement to nursing facilities for bed hold days during hospitalizations and therapeutic leaves of absence. This resolve is fairly straightforward. It requires the Department of Health and Human Services to continue to provide reimbursement under the MaineCare program to nursing facilities for direct care costs on bed hold days during hospitalizations and therapeutic leave absences. This would be retroactive to October 6th, 2020. And it is just about that straightforward. So I'm going to let people coming after me to talk about the need for this reimbursement. Thank you, Mr. Chair.
Thank you for bringing that forward, Representative Craven. And Mr. Erb are there any questions for, I don't see any, so we'll go to Mr. Erb.
Good afternoon again, Senator Claxton, Representative Meyer, members of the committee. My name is Rick Erb. Pleased to testify in support of LD 1197 and want to thank Representative Craven for sponsoring it. This issue should sound familiar to all of us, as it was an issue for us during the hearings on both the supplemental budget and the biennial budget. There were proposals in both budgets to eliminate reimbursement for direct care costs during the bed hold period. Our point has been that actual costs do not decline when 1 or 2 residents are temporarily away from the facility. Reducing the number of staff is simply not practical. Residents need to be reassured that their nursing home bed will still be there for them after hospitalization or any other temporary absence. But it's not fair for the nursing home to receive less compensation during this period. This committee has already voted against cuts like these twice, and I urge you to put your support for bed hold payments into statute as called for by LD 1197. I'm happy to answer any questions that you have.
Are there any questions for Mr. Erb? I don't see any. So that'll conclude the public hearing portion of this work. Are there any questions for Ms. Broom? I don't see any there either. Okay, so I don't see anybody else who wants to testify for or against or neither for nor. So we'll go now to Senator Baldacci and LD 949.
And I also have LD 873. Do you want to?
The floor is yours.
Okay. Well, I would introduce both bills if that was okay in the interest of time.
Sure, that's fine.
LD 873 is a resolve to waive reductions to nursing facility reimbursements resulting from the Payroll Protection Program loans and grants. This is to address an issue where the Department of Human Services was deducting amounts from the reimbursement to nursing homes by the value of the PPP loans that institutions received. And as we remember with the tax conformity debate, similar issue here in terms of supporting the operation and the employees of a nursing home is extremely important, and they should not be basically punished for getting federal relief that all other businesses were getting. We also know that the number of closures of nursing homes over the last 6 or 7 years has been quite dramatic, and it hits particularly hard rural Maine, and obviously it hits our seniors, people with very, very limited economic as well as healthcare options. So supporting nursing homes helps support our communities, particularly in smaller towns. Bangor has probably half a dozen or more nursing homes, either connected with Northern Light or that are independent. So the number of people served by nursing homes just in Senate District 9 is well over a couple hundred. But I think this problem replicates itself and is particularly worse in rural areas like Aroostook County or Washington County, or other places that have very small towns and they have a nursing home that many people go to. So this bill and the companion bill are to help nursing homes. This bill is about the PPP. The other one is to restore a temporary rate increase. They're both emergency bills that have been requested by nursing homes in order to have better long-term financial security Many nursing homes are operating at the margins. I don't want to see any more closures. I don't want to see even further reduced options for our elderly in this regard. This is an amazingly important service and care for hundreds of thousands of elderly people. So I ask for your consideration of those two bills, both as emergency legislation. Thank you.
Thank you, Senator Baldacci, for introducing those
Oh,
two.
and one more thing is I think, thank you, Mr. Chairman. I think that Rick Erb is going to indicate, he just sent me a note like 10 minutes ago or 15 minutes ago, that the Department of Human Services is reversing its policy as it relates to LD 873, and which is great news. I want to see the LD pass, though, to make sure, in statute that this doesn't become a recurring issue that we have to deal with. So I just want to let people know that I thought that was good news that they're at least listening to what we're trying to get done. So thank you.
Thank you for that. And the reason we did this is that Senator Baldacci needs to get to the next committee meeting. So now we'll hear again from Mr. Erb.
Nursing home day continues. Mr. Chairman, do you want me to address both bills?
If that's the easiest way for you, whatever it takes to get us educated is the question.
All right, well, I will go ahead with 873 then. Thank you, Senator. Thank you, Representative Meyer, members of the committee. My name is Rick Erb. I'm President and CEO of Maine Healthcare Association. When the federal government announced the payroll protection plan almost a year ago, it was greeted with overwhelmingly positive response by businesses and employees. It clearly helped protect jobs that would have been otherwise lost due to COVID-19. Unfortunately, not every nursing home qualified for PPP. Generally, this was done due to ownership structure, and there isn't much that we can do about that. That's the federal regulation. However, another concern came up when it appeared that DHHS audit would be offsetting any forgiven loan amounts by reducing the amount of main care payments the facility was allowed to keep. I don't know of any other employer who was treated this way. As difficult as the pandemic has been for long-term care providers, this seemed incredibly unfair. Since LD 873 was filed, there have been continuing discussions with DHHS on this essentially unprecedented program. My understanding is that there is now guidance released by DHHS stating that they will not be offsetting the PPP funds. If this is correct, the unfair burden on nursing facilities will have been eliminated, and we're appreciative of that. I would urge the committee to verify with DHHS that this is indeed the case, and as Senator Baldacci said, still pass the bill. I'm available for any questions you have. I see that there is someone from DHHS audit that's also logged in, so perhaps he will comment on it. But that was the understanding that I got from the department. So thank you very much.
Thank you for that. Are there any questions for Mr. Erb related to 873? Yes, Representative Connor.
Yes, thank you, Mr. Chair, and thank you, Mr. Erb. My question kind of stems for some self-education on my own part. During the pandemic, did revenue cease coming into nursing homes through Maine Care or Medicare or any other revenue sources? Did those dry up? Is that why those institutions were looking for PPP loan assistance, or were Medicare and Maine Care payments still coming into those facilities?
Payments were still coming in. What we have seen and still continues to see is reduced occupancy. Some are hovering just above 50% occupancy. Prior to COVID-19, the average was close to 90% occupancy. So that's a real challenge. And we'll be talking about that in other bills. But besides the fact that COVID-19 brought on many new and additional costs, one of the biggest factors is low occupancy and therefore lower revenues.
Follow up, Mr. Chair?
Please.
So in terms of, equating this to a normal business, if occupancy is down, are the expenses still the same? Why would the expenses be the same if occupancy is down and there's not a need for caring for more people? Why would the expenses remain the same? I'm just out of curiosity.
Sure. It's not that different than what we were talking about on bed hold days. There are a lot of costs in nursing homes that are fixed, literally fixed, because that's a classification, and more figuratively, that you will not see a reduction in cost that parallels a reduction in the number of residents. There are just too many costs that don't change.
Thank you. That's all I have, Mr. Chair.
Okay. Representative Perry? When you're unmuted?
About that.
That's good.
I'm actually reading the department's rationale for first of all, refusing to do that. And I'm wondering if they have given or if they have looked at this differently, because they had said with federal grants would offset the operating cost of a nursing facility before determining allowable costs for reimbursement. Are they looking at the PPP loans differently at this point? I know that the expenses have gone up as a result of, the kind of infection control that had to happen, the PPP, the personal protective equipment that was needed that nursing homes did not have, as well as increased training. Did they give any explanation as to how they were looking at this differently?
I can't really comment for the department. What this started off, as I understand it, is as the position that if federal funds were received, then it was that much less in state funding that was required, and they were going to offset. We did have lengthy discussions with the department on that, and my understanding is that they changed their policy, but I really would defer to the department to address that.
Thank you.
Thank you.
I guess to jump on that, I would like to hear from the department in terms of how they've looked at that.
Okay. Are there any other questions to Mr. Erb? Okay, I don't see any. I don't see anybody else testifying for or against. We are joined by Mr. Downs. Welcome. Testifying neither for nor against.
Thank you, Senator Claxton. My name is Herb Downs. I am the Director of the Division of Audit for the Department of Health and Human Services. Senator Claxton, Representative Meyer, I am members of the Joint Standing Committee on Health and Human Services. I already told you I'm Herb Downs. I'm here to speak neither for nor against LD 873, a resolve to waive reductions to nursing facility reimbursement resulting from payroll protection program loans and grants. I'd like to offer the following information for your consideration. LD 873 seeks to require Maine Care to waive the offsetting of any funds received by a nursing facility provider from the Paycheck Protection Program during the audit of the provider's Maine Care cost report. The department is currently not requiring nursing facility providers to offset the PPP funding against their cost on the Maine Care cost report in alignment with the objective of LD 873. If we get clear guidance that these funds must be offset, we will adjust the audit to reflect the proper application of the PPP funding. Failure to follow CMS guidance would result in the department paying any costs that should be offset with all general funds. The Department of Health and Human Services has been working to get clarification from the Centers on Medicare and Medicaid Services, CMS, on how PPP funds should be treated for cost-settled providers. CMS issued COVID-19 frequently asked questions for state Medicaid and Children's Health Insurance Program agencies, updated January 6, 2021. They specifically address offsetting of some provider relief funds, but not all. Their response to a question on how states should treat provider relief fund revenue for purposes of Medicaid cost reimbursement was, when a state pays for Medicaid services using cost reimbursement, the provider is not required to offset Medicaid costs by provider relief general and targeted distribution payments. Unfortunately, they did not identify PPP funds as being exempt from offsetting. We have asked them to clarify this issue for us. We have received a response that they are considering our question. Our currently approved state plan amendment requires that federal grants be offset against operating cost of a nursing facility provider before determining the allowable cost for reimbursement under the Medicaid program. This follows the federal regulation that no individual or entity may receive money from the federal government twice for the same purpose. There has been guidance from CMS for Medicare fee-for-service billing providers directing them not to offset PPP funds on the Medicare cost report. As stated previously, CMS has not given the same guidance for Medicaid agencies. The goal of the department is to provide the available relief to nursing facility providers while maintaining compliance with federal regulations. Thank you for your time and attention. I'd be happy to answer your questions you may have and to make myself available for the work session.
Are there any questions for Mr. Downs? Yes, Senator Baldacci.
Yes, thank you, Mr. Chair. I just want to thank Mr. Downs. I know that this has been an issue of concern for many nursing homes, and I just appreciate you being completely on top of it and look forward to trying to figure out where the federal government lands, but I appreciate your efforts. Thank you, sir.
Are there any other questions of Mr. Downs? I noticed that your testimony isn't on the website yet. I know that there's been significant delays in getting that stuff posted, but if you haven't sent it in, would you please?
I believe it has been sent in, but I can make sure it gets sent in.
And I wouldn't be surprised that it's been sent in, but the posting process is a little slower sometimes.
It's actually on there, Senator Claxton, because I read it along with him.
Really?
Under the 873.
Well, it's not on the, well, anyway, we'll work that out, but it's not where I want it. Okay. Thank you, Mr. Downs. Are there any other questions? I don't see any, so thank you for being here.
Thank you.
I don't see anybody else to testify for 873. So that'll conclude the public hearing portion of consideration of that bill. And now we'll go to 949. That's already been presented, but there are several people to speak. Welcome, Mr. Bolduc. When you're unmuted, please join us.
Sorry. Good afternoon, Senator Claxton, Representative Meyer, and members of the committee. My name is John Baldock. I'm the Executive Director of Odd Fellows in Rebecca's Home of Maine. I'm testifying in support of 949, LD 945, and I thank you, Senator Baldacci, for sponsoring this. In order to retain staff last March, my board of directors elected to take the following steps. Move the annual July pay increase up by 2 months. We increased the percentage amount of the increase. We started giving weekly heroes pay bonuses of $100, and we institute a $5 an hour stipend for any staff who care for a COVID-19 resident. My board of directors asked me if we could afford this. My answer was no. Unless funding comes in from the state, because we are over 95% main care funded, we stand to lose potentially hundreds of thousands of dollars, which was over 300,000 we lost last year. We are a small facility with a $3 million budget, so that is very significant. I told my board that we needed to protect our residents first and foremost in keeping staff. In light of the current staffing crisis and childcare problems, was our best way to do that. They agreed and approved the heroes pay. None of this has been very easy for an independent nonprofit facility like ours. The state needs to recognize that and find a way to help us pay for the costs that are directly related to COVID-19. I don't understand why more federal assistance sent to the state hasn't been used to support long-term care. Because of the heroes pay that we provided and the excellent work of our staff, we were able to use 0 temporary agency staff. Other facilities aren't so fortunate and are paying sky-high agency rates. So whether by increasing pay or bringing in agency staff, the cost payroll is tremendous. Although we had our first residents with positive tests between the first and second doses of the vaccine, I'm grateful that we suffered no deaths. And I know that other nursing homes have been hit harder than us, and I truly feel for them. Because COVID-19 has made people very wary about admitting their loved ones to a facility, our occupancy rate, which allows us to squeak by in a normal year at 99% occupancy, is down by 10%, from 99 to 90. We have been paying top price for supplies while promised assistance isn't coming. We received a PPP loan only to learn that the state will probably take it back. Well, I just heard what was said, so thank you. There is federal money available to help us. I am on a national board of administrators and owners, and they're all receiving this money, yet Maine sits on it or wants to use money meant to help us to meet other budget needs. There is no question that facilities like mine throughout the state have been devastated both monetarily and emotionally. The state has the ability and the responsibility to step up for our senior population. So please, please help us take care of the citizens you represent by supporting this bill. I'm happy to take any questions.
Thank you, Mr. Bolduc. Are there any questions? Yes, Representative Connor.
Thank you, Mr. Chair. Thank you, Mr. Bolduc. Just one quick question. For the patients that you did have in the facility, were their expenses covered by Maine Care? Were you paid for them by Maine Care?
That's a good question. The answer is, for the most part. As I said, we lost $320,000 last year. That represents the amount of money we were not paid for by the state to cover our costs, to take care of the residents.
Okay, so you did have residents that were being cared for that were not paid for by Maine Care or any federal dollars. Is that what you're saying, sir?
All of our residents were being paid for, but the rates were not high enough to cover the costs of their care.
Thank you, sir. That's all I have, Mr. Chair.
Thank you.
Any other questions for Mr. Bolduc? And how much, sir, I have a question in terms of how much your expenses would have increased year over year outside the realm of a typical year from, comparing 19 to 20. Some of that was personnel costs and some of that was additional costs for infection control. Is that correct?
Yes, absolutely. I mean, in a regular year, prior to the increase in minimum wages, our annual expenses went up very little. As we are always looking to make sure keep our expenses down because we have to be tight. So less than 1%, except for when the raises had to be put in. We were increasing by about 3% more per year for the last few years, but we were still keeping up with payment pretty well. And the prior year we were net income of $20,000, which was tremendous for us. We were usually in the hole. And this past year after that, last July, we ended up $300,000 in the hole. And who knows, it's hard to tell where we're going to be this year, but it's going to be likely in excess of that if nothing's done.
Okay. Thank you for that clarification.
Thank you, sir.
Okay. Thank you for being here. Let's go to Ms. Pelkey.
Good afternoon, Senator Claxton again, Representative Meyer, and members of the committee. My name is Wanda Pelkey, and I'm board chair for Maine Healthcare Association, and I'm also CFO for First Atlantic Healthcare, a company that has 20 nursing facilities and residential care facilities throughout Maine. We care for 1,500 residents daily. Today, I'm testifying in support of LD 949, and I thank you, Senator Baldacci, for sponsoring it. These are unusual times, and frankly, it's very concerning for our company's future and the elderly who we serve. In terms of lost revenues for us, our usual occupancy revenue of around, our occupancy level, I should say, of around 90%, declined in 2020 and averaged 84% for the year. Today, as we are in early April. We're averaging in the low 70s, and that's closely aligning with statewide NIF occupancies. And so far, there's been little sign of occupancy recovery. That is an enormous revenue loss that can't be made up by cost cutting alone. Add to that staffing pressures. Roughly 1/3 of our direct care positions are vacant, and that requires us to rely heavily on premium pay programs, as Mr. Baldock said in his facility. And for us, we rely too on expensive agency nurses. These shortages are today limiting our ability to admit new residents and causing backups in hospitals. But beyond increasing pay, I'm not sure how to address this issue. Yet with empty beds, additional pay increases are unaffordable. For us, it's a classic catch-22. And I'm further concerned that restaurants and other hospitality businesses that are gearing up for the summer will further compete with us for workers. And then lastly, COVID-19 costs. While outbreaks in our company did subside, COVID costs of PPE testing and COVID supplies have not. They're still very costly and are largely unfunded without additional relief money. As a result, these factors are fast depleting our cash reserves. I realize I speak for other Maine nursing facilities too. Last year's relief funds from the CARES Act and Maine Care temporary rate increases, also called TRIs, they have already or are quickly running out. Rick will share in his testimony, there are various ways to support our need, whether through a restored TRI or another approach. One fact is clear. The funding relief for us is more important than ever. Our facilities this year won't receive funds direct from the federal government like they did last year. The American Rescue Plan funds will flow through state government first. You being the gatekeepers, I urge you to make our elderly a priority. Thank you.
Thank you for that testimony, Ms. Pelkey, and I'm sorry if I messed up the sequence of testifying.
That's
If you had
certainly
it-
okay.
If you had it well orchestrated. Are there any questions for Ms. Pelkey? Yes, Representative Connor.
Thank you, Mr. Chair. I guess I'm the only one asking questions today. I apologize for so many.
No.
My
Over here.
question is out of curiosity, Ms. Pelkey, and thank you again for your wonderful testimony.
You're welcome.
What do the facilities of your association have plans? Let's just assume that more and more elderly folks are choosing not to go into nursing facilities, but rather stay with family and whatnot due to the lingering effects of COVID. What are your facilities' plans moving forward if the new occupancy rate becomes the standard occupancy rate? What does the future look like for those facilities without further state and federal funds rolling in?
Now, I think that's a great question. I think, honestly, one of the big drivers for why we don't have higher occupancies or recovering occupancies is the workforce issue. We feel that there is demand for our services still, and by virtue of listening to hospitals talk about the number of cases backing up in the hospitals, I have to believe that that's true. And we are voluntarily not admitting in many of our locations just because of the staffing crisis. If we could solve for that, I think we could fill our beds. I would add to that the demographics of Maine and the aging elderly population will ensure demand for the future. So while the workforce may not be the full address of the issue, it's going to be a large part of it. So I think, for now, providing funding to enable us to pay for the staff that we need is vital.
A follow-up, Mr. Chair, if I may?
Please, sure.
So I'm a bit confused because I think somebody just testified that the occupancy was down, the staffing was still at the current level, and that's why the funds were needed to cover staffing. So I'm confused as to your statement that you feel that the occupancy is down because of staffing. Can you elaborate on that?
Sure. I can't speak for Mr. Baldock's situation. Clearly he's normally operating at 99% occupancy. Pre-pandemic, we've been around 90% occupancy. For us, our situation sounds like it's a bit different from Mr. Baldock's. For us, staffing is much more of a challenge, trying to find new recruits into our business to allow us to take more admissions. In fact, I kind of envy Mr. Baldock in his regard. At least he has staff. Yes, they are seeking more money to stay in place. For us, it's a bit more critical than that.
Thank you. That's all I have, Mr. Chair.
Okay, thank you. So what percentage of your overhead or in general across your organization is personnel as part of your total spend?
Oh, I would say that it's about 60% of our total spend.
Okay. And at this point, you have empty beds because you can't find people to work.
That's
Okay.
correct.
All right.
I know you would think that it would be very easy to staff with our own. It's really a paradox. We're finding that we're using as much agency as ever before. I don't really understand the reasons why it's hard for us to find staff right now, but it is.
Well, it's probably related to some of the same reasons that people don't want to go into nursing homes over the last year. That don't want to work in that environment without knowing truly what goes on
no
there.
doubt.
Yeah. Okay. All right. Thank you. Appreciate that.
You're welcome.
Mr. Erb, I keep trying to promote you, sir. Mr. Erb, welcome back.
It's happened before.
I know.
Means I'm around too much. Good afternoon, Senator Claxton, Representative Meyer, members of the committee. My name is Rick Erb. I want to thank Senator Baldacci for sponsoring LD 949. A year ago, we were just learning what profound effect COVID-19 would have on us all. Maine's long-term care facilities have performed admirably during difficult circumstances, but this has come at a cost. Last April, MHCA approached the Department of Health and Human Services with our best estimate of the cost to protect our residents and staff going forward. DHHS promptly approved temporary rate increases for facilities with the understanding that the rates would be reviewed and possibly adjusted in June. This increase was $23.58 per day for nursing homes, $16.10 per day for PNMI assisted living. We were surprised and disappointed to see that the rates were eliminated in June, with the exception of payments to the facilities in the midst of an actual outbreak. The main care rates would no longer reflect the ongoing cost to keep the virus out of buildings. To make matters worse, the COVID-19 surge in Maine actually came after the TRI had been discontinued. Maine providers have seen a dramatic increase in the cost of labor as workers became harder to find and agency rates became subject to bidding wars. On Friday, I saw agency rates of more than $150 per hour quoted for out-of-state RNs and more than $70 per hour for CNAs. PPE costs skyrocketed and prices rose due to boosted demand. Staff and resident testing increased, partially paid by the state, but not entirely. At the very same time, facility revenues dropped as average occupancy rates fell by more than 15%. Some are lower, far lower than that, and according to the state's own figures, have yet to recover. Earlier in the pandemic, some federal funds went directly to these facilities, and this became critical to their financial survival. But the frequency and amounts of these payments dwindled at the very time that Maine was dealing with the surge. I was in a call at noontime today. It is not looking good for additional federal money coming. Our long-term care providers need your help now. Maine's temporary increases were allowed to lapse, even though demands on the facilities and staff were accelerating. New relief could be paid for through several means. One, federal funding received by the state, first through the CARES Act, more recently from the American Rescue Plan Act. Two, the 6.2% increase in Medicaid matching funds that Maine continues to receive. And three, lower occupancy that means the state's total costs actually been reduced, even though our cost per resident has soared. Whether it is through LD 949 or any other vehicle, the state needs to provide relief to these facilities that have been on the front lines of COVID-19. We have observed other states increase their provider rates during the pandemic while Maine remains silent. Facilities never want to publicly say that they are on the brink because they know that makes the situation that much harder, but that's exactly where they are. I'm actually quite encouraged that DHHS has agreed to meet with us on Friday to discuss these very matters. I look forward to it and hope it generates positive results. I'm happy to answer any questions the committee has.
Thank you, Mr. Erb. Representative Connor?
Not this time, Mr. Chair. Thank you, though.
Okay, okay.
I was looking forward to it.
Yeah, he's ready. He's ready. I don't see any other questions of Mr. Erb. So, and there's nobody else to testify that I can see for nor against, neither for nor against. So I think at this point, we'll conclude the public hearing portion on LD 949. Thank everybody for coming for that testimony. And
Mr. Chairman?
yes.
I
Mr.
just want to
Senator.
thank Senator Moore as well as Representative Stover and Representative Madigan for co-sponsoring the bill, the temporary rate increase bill. I think I'm happy to work on it at the work session, but I was wondering on the first bill on the PPP money, I'm hoping that we can have a work session on that as soon as possible so that we could get it ratified as soon as possible, but I'll leave that up to the committee. I just want to emphasize that they're both emergency bills. So
Thank you.
okay, thank you.
Okay,
I
thank
will
you.
talk to you folks later. Thank you.
All righty. Next up, after a 5-minute break, we'll go to LD 958. That'll get us after 2 o'clock for Senator Maxman. And then we'll hear the bills in order after that, 11:39, and fill in where we've missed. So why don't we take a 5-minute break, get back here at 2:03 and be ready to hear 958. Thank you all. before we resume the work of the Health and Human Services Committee. And if Mr. Downs is still listening, I appreciate your submitting your testimony online. I did find it. I leave the HHS committee website open so much, I need to remember to refresh it every once in a while. Once I did that, Senator Moore was absolutely correct. All right, so this brings us back. We're going to hear now from Senator Maxman about LD 958. Welcome, Senator.
Hello there.
Welcome.
Senator Claxton, Representative Meyer, and Honorable Member Human Services Committee. My name is Chloe Maxman. I represent Senate District 13, which is all of Lincoln County except for Dresden plus Washington, Windsor, 27 towns in the Mid-Coast. Thank you for having me here to speak in support of LD 958, a resolve directing the Department of Health and Human Services to conduct a review of rules governing in-home personal care assistance services. The idea for this bill came to me from a woman, Jill Harrison, whose mother is a constituent. Jill is here today to share her family story, so I will let her tell her story. But in short, her 80-year-old mother has received personal in-home care services from a local agency. As Jill wrote to me in her first email, quote, "These services were subpar, little to no oversight or supervision, and criminal charges are currently pending against at least one of their workers. Despite repeated concerns, the supervisor never followed up on the concerns, and my mother's health and well-being deteriorated as a result." Jill will tell the rest of her story later. There are untold consequences to this lack of oversight. As far as we have been able to ascertain, there is little legal recourse for Jill and her family. An employee at this particular facility was accused of felony theft charges and a misdemeanor charged while employed there. But this isn't going to trial for a few reasons, one of which is that Jill's mother, who has Alzheimer's, could not be a credible witness. This is obviously a heartbreaking situation. That is where this bill comes in. Private home care agencies do not receive the same level of oversight and guidelines as home care agencies in Maine, leaving residents vulnerable. I want to be clear that I am not persecuting any one agency or the good work of so many Mainers who provide invaluable in-home care services. I am simply bringing to your attention a very sad situation that calls on our oversight. As you can see in this bill, this resolve requires DHHS to review rules that relate to the direct care services provided in the home to assist individuals. The review must examine how entities providing direct care services to affected individuals provide information such as advance notice of staff absences, termination of services and training requirements, and ensure supervision and quality care and protection of vulnerable people receiving care. The department would submit its findings to your committee no later than January 1st, 2023. I just wanted to add a couple more points here. Jill has done extensive research and interviews with folks at home health care agencies. I encourage the committee to ask her questions about her findings as they might not fit in her 3-minute window. I also would add that the scope of this bill is quite large to start with, and I'm willing to work with the department, advocates, and the committee on honing in on specific sections. There is clearly a need for oversight here, though, and I hope that we can keep that priority in mind. I appreciate the committee's attention to this issue, and I am happy to answer any questions.
Thank you, Senator Maxman. Are there any questions for the senator? I don't see any right now, so thank you for bringing this forward. I was looking for Don Lawson Stoops. If he shows up later on, we'll let him testify. Next, we'll go to Patricia Thorson. As soon as you're unmuted.
Thank you. Senator Claxton, Representative Meyer, and committee members. My name is Patricia Thorson, and I am the Ombudsman Program Manager. The Maine Long-Term Care Ombudsman Program is a statewide nonprofit organization that provides advocacy for older adults and adults with disabilities who receive long-term services and supports in all settings. We serve residents in nursing homes, assisted housing, adult day programs, and recipients of home care services. Additionally, we serve patients in hospitals who experience barriers in accessing long-term services and supports. We're pleased to provide testimony in support of this resolve that requires the department to review rules that relate to direct care services provided in the home to assist individuals with the activities of daily living and instrumental activities of daily living. The review must examine how entities providing direct care services to affected individuals provide information such as advance notice of staff absences, termination of services and training requirements, and ensure supervision and quality of care and protection of vulnerable people receiving care. The department is required to submit its findings and recommendations to the Joint Standing Committee on Health and Human Services no later than January 1st, 2023. The rule chapters listed in the legislation have program eligibility ranging from someone who may only require limited assistance with bathing, dressing, and light housekeeping, to individuals who are nursing home level of care, require extensive assistance with activities of daily living, and may have complex medical needs. For this reason, we believe that's important to review the various rule chapters and implement consistency in provider agency expectations. For example, in Section 20 regulation for home and community-based services for adults with other related conditions, as well as in Section 18, home and community-based services for adults with brain injury, the rules state under provider qualifications and requirements that once a provider has been authorized to provide services, the provider cannot terminate the member's services without written authorization from DHHS. In comparison, Section 19, home and community benefits for the elderly and adults with disabilities, has no requirement for the provider agency to provide notice of termination of their services. The same individual eligible for services on Section 18 or Section 20 may receive services on Section 19 if they're unable to access the Section 18 or Section 20 due to a waiting list for funding or services. Another example is a requirement in home and community-based services, Sections 18, 20, 21, and 29, that staff must receive training on reportable events, and this is not required in HCBS Section 19. Additionally, Chapter 129, rules and regulations governing in-home and personal care and support workers, have not been updated since they were promulgated in January 1999. These rules do not include protections for home care consumers, and we've attached a copy for your reference. We're aware of many consumers who do well at home in spite of extensive medical needs when given the right kind of support. We want to point out that there are many dedicated caregivers working in home care who provide excellent services. Having said that, we do receive complaints about personal care agencies from home care consumers and their family members. The most common complaint is regarding personal care assistants not reporting to work at the scheduled time and no one notifying the consumer about the absence. Without adequate notice of the loss of staffing, consumers are frequently left without services, increasing their risk for institutionalization. We believe there's a need to review each of these rule chapters and ensure a basic level of requirements, including but not limited to a requirement that provider agencies provide information to the consumer on their rights and protections, provide advance notice of staff absences and termination of services, and provide training to direct care staff on completing reportable event forms. Thank you for your consideration.
And thank you for your testimony. Are there any questions to Ms. Thorson? I don't see any at this time. And so the other person testifying in support is Ms. Harrison. Welcome.
Hi, thank you to members of the Health and Human Services Committee. I am writing to support LD 958. I'm representing my mother, who is the victim of unscrupulous and criminal conduct with home health care employees, or often called, they are independent contractors. So the reason for contacting members of this committee is to really try to build support for more elders to remain in their home. But the care is substandard and there's very little oversight, as Senator Maxman already indicated. There needs to be systemic change. The quality of care that is available in nursing homes should also be available in clients' homes. This means oversight and the protections that are in place for long-term care facilities and nursing homes should be considered for home health care agencies. We know that clients do better in their home, and yet the same protections that they get in a facility are not available to them with home health care. So we need more extensive caregiver training. I know that in one interview, an owner and operator of a home health care agency in Boothbay Harbor said she doubted that PSS or personal support specialists and CNAs would pass a drug test, right? And we need more supervision. The supervisor of the healthcare agency that I used from Damascata was actually selling her clients drugs and pleaded to a lesser charge, and there are more criminal charges pending. We had extensive family heirlooms stolen, thousands and thousands of cash withdrawn with their debit card. And so there are no protections in place to support clients, especially since as a faculty member, a college professor who works out of state, I can't oversee what's going on with my mother's care. One agency uses GPS trackers so that they have to clock in. And even though we had video cameras in the home, they were routinely unplugged, presumably to vacuum, although given the filthiness of the home, that was never the case. So we need more background checks, we need more regulations. I have to say that the Attorney General's office completely blew it when the supervisor asked that a couple of her potential clients, or rather employees, get waivers because they did not pass a background check. There were at least 2 people who do not pass a background check. And yet, if we had a national registry that we could use, a national background check, we would see that one person served extensive time in prison for aggravated drug trafficking, but in another state. There was another one who also was arrested and charged with a minor misdemeanor shoplifting. And that was never picked up with a state BCI. I don't know if you all call it BCI, but that's the criminal background check. So we've got a number of issues going on here. We are lacking staff. CNAs need to be able to remove the sort of indentured servitude that Maine Healthcare sort of captures them in by allowing them to have their certification renewed with the minimal support from a registered nurse. But there's no such renewal option for CNAs who are working in home healthcare. So trying to get qualified staff and actually getting the training programs that CNAs need are really, really critical. For example, it claims Maine Healthcare. Okay, thank you. Maine Healthcare claims that there is a program at the Boothbay Harbor High School, but there is no such program. So I have some suggestions, and I've been doing a little research on this. I'm happy to answer any questions that you have related to LD 958. Thank you.
Thank you. And I'm sorry to hear that your family had to go through all of that. Thank you for being here. Yes, Representative Madigan.
Thank you, Senator. Thank you, Ms. Harrison, for being here and for taking such good care of your mom. I also do a lot of caregiving for my parents. And I'm wondering, you said you had some suggestions and what you found out. I'm wondering if you could share those with us.
Yes, I'd be happy to load them onto the website. I think that one of the most important suggestions is to see if we can get the personal support specialist, which is the minimum requirement of 50 hours, sort of upgraded with ongoing training and support. We need to attract people who really see this as a career choice. And it was interesting that the owner and operator of a home health care agency in Boothbay Harbor said that she doubted even paying $20 an hour would actually generate the kind of staffing shortages that would be removed. So she said drugs are a huge issue and we need drug screening, and we also need more ways in which people who are interested in this type of career choice can get the training and certification that they need. They're 2 different animals, she said, CNAs in nursing facilities versus home health care agencies. And so the least structured, the least supported, the weakest type of personal support specialist is actually in the home. And the other one was clearly about the national database and doing background checks. The other one that she recommended is that we really need to remove independent or family support. There is absolutely no oversight for independent caregivers. They don't operate under any kind of agency or regulation whatsoever. And so that allows for some of these criminals, for example, they can argue that they have been hired by and spent many years working for a home health care agency, get employed as a private independent home healthcare aide, and then also repeat the same levels of behavior. It is absolutely awful what happened to my mother. And the reason for this bill is so we can provide protection so it won't happen to anybody else. I bet there are plenty of victims out there. We're an aging population. This is not going to go away.
Thank you for being here.
And yes, Representative Jabner.
Thank you very much, Senator Claxton. I appreciate that. Thank you for your testimony. Yes, there are many families, I am sure, that have been victimized in this manner. This is a really important bill to bring forward. I am really looking forward to the work session. I have some information that I would like to request, if possible, to get a statement from the Attorney General's office concerning this specific issue and how they plan to perhaps pursue the national data bank and everything, so that we can assure our families that things like this won't happen again.
Thank you.
So that's directed to Ms. Brum as much as anybody. Okay, yes, sir. Representative Stover.
I apologize for that. My buttons got confused. Good afternoon, Ms. Harrison. I just want to thank you for being here today. I represent Booth Bay Harbor, and I'm sorry that that happened to your mom. And I hope that as time goes on, there's more resolution to your case. I appreciate you being here today.
Are there any questions of Ms. Harrison? The only one I have is to make sure that your testimony, your suggestions get posted to our committee so we can review that in anticipation of the work session. And one of the concerns was that the request for review is a little non-specific. So if you could give us 3 or 4 things that were the highest priority from your experience, you can give us the rest of them too, but just help us who haven't been there necessarily focus a bit on what really needs to get accomplished in terms of direction. Review is a kind of a nebulous passive term compared to fix, or, so if you can give us a little direction, that would be helpful.
Yes, there was just an article in the New York Times on Sunday that talked about village communities for elderly people. It takes a village, that whole phrase, and they're having some success with that. So if we want to think really big, if we want to think about real systemic change, then we need to take a look at some of these other models that are going on in other states.
Okay. Representative Stover? Nope, that button got confused again. Okay, all right. Any other questions before we proceed? I don't see any. Again, thank you for being here, Ms. Harrison.
Thank you all for the work that you do. I really appreciate it.
All right, I don't see anybody else to testify for nor against, nor neither for nor against. So that'll conclude the public hearing consideration of LD 958. Are there questions or other data requests of Ms. Brum, Anna Brum, for the work session? Yes, Representative Meyer.
Thank you, Mr. Chair. Yeah, I'd like to know of any other states that have regulatory oversight over these agencies, and if so, what is the enforcement mechanism?
Representative Craven. When you unmute.
Sorry, thank you, Mr. Chair. I'd like to know if the department has any models that they could use and what can be done about private contractors that has no oversight and other than the MRS or the IRS or somebody like that being able to intervene. Does the department have any kind of oversight at all over private contractors that would be very difficult to do a background check on or be able to be able to provide any oversight for them.
Okay. Representative Madigan?
Yes, thank you. I would like to know what the, well, I assume to be certified as a PCA or a CNA, well, we know as a CNA, there has to be a certain coursework done, and what the continuing ed requirements are, and for particularly those agencies that are providing home care as opposed to kind of nursing home or assisted living care, how that's followed up on, and are each of those agencies licensed? And I guess I want to know more about how that staff is, what oversight there is.
Any other questions? So I just want to note that we had a request to look at the big picture and how this is done. And I don't think we have the information to be able to start that conversation. So maybe we ought to hear from Director Saucier about what their vision is for how we're going to pay attention to these kinds of issues. Where are we headed? What are the roadblocks, and is there some legislative help in that work? So for a future date, maybe we'd invite Director Saucier to come back and give us a big picture look, so we look for opportunities to help. Any other comments? Yes, Representative Meyer.
Thank you, Mr. Chair. I'd be curious to know how many complaints of this nature the Ombudsman's long-term care Ombudsman's office receives yearly.
I'll bet you Ms. Thorson can help with that.
Indeed.
So now that Anna has our homework, are there any other questions or concerns? Okay, good. All right, so that takes care of LD 958. Now we can go to 11. If I see, yes, Representative Libby is here. 1139. Welcome, Representative Libby, as you get pulled into the committee. Welcome, Representative Libby.
Thank you very much. I think I transferred over successfully.
You did. If you were going to HHS.
That was my intention. Senator Claxton, Representative Meyer, and distinguished members of the Committee on Health and Human Services. My name is Laurel Libby, and I reside in Auburn. I represent House District 64, which is Minot and part of Auburn. And I come before you today to present LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. Since March 2020, nursing homes and assisted living facilities in Maine and across the country have largely been locked down, with family visits a rarity outside of window visits. The rationale: we have to protect the vulnerable. In the spring of 2020, Auburn resident Audrey Murphy's father fell at his assisted living facility. Upon discharge from the hospital, he was sent to a rehabilitation facility. With no family visits to provide familiarity and routine, his mental status deteriorated and he was discharged to a memory care unit. Midsummer, Murphy got a phone call notifying her that he was dying and to come quickly. Several family members were able to be at his side for a short time and then told to leave. Her father died alone that same night. She attributes her father's rapid decline, physically and mentally, and subsequent death to isolation, and says that no one should be forced to die alone. According to the CDC, recent studies found that social isolation significantly increased a person's risk of premature death from all causes, a risk that may rival those of smoking, obesity, and physical inactivity. Social isolation was associated with about a 50% increased risk of dementia, and loneliness among heart failure patients was associated with a nearly 4 times increased risk of death. The isolation is robbing them of whatever accelerates the aging process. Said Joshua,
Excuse me.
Yes?
Something with the audio is going crazy. Is your mic super sensitive or on your desk or?
It may be. Let me see. I'll adjust it.
Everybody else seems to be muted, save me, and I was muted
Okay.
at the time. Okay,
Is that better?
that's better.
Okay.
Thank you.
The isolation is robbing them of whatever good days they have left. It accelerates the aging process, said Joshua Uwe, associate professor at the University of Pennsylvania's Perelman School of Medicine. You see increased falls, decrease in strength and ability to ambulate. You see an acceleration of dementia because there's no rhythm to your day. Around the country, there is a new cause of death listed on death certificates: social isolation and failure to thrive. Failure to thrive is a medical condition characterized by reduced appetite, weight loss, lower activity levels, and often with depression, closely linked with isolation. A Chicago area nursing home found that 2/3 of their residents lost weight between December 2019 and the end of April 2020. A pre-COVID study out of Norway showed a median survival of 2.2 years once admitted to a nursing home, with a yearly mortality rate throughout the 3-year observation period of 31.8%. Another study performed in the US in 2010 with 8,433 participants found the median length of stay before death was 5 months, with 65% dying within 1 year of nursing home admission. We've seen outbreaks of unprecedented numbers in long-term care facilities in Maine. I asked a nursing home primary health care provider if it was possible that COVID restrictions were actually contributing to these outbreaks. Their response: a compromised host is more susceptible to disease. So yes, failure to thrive in residents resulting from the restrictions could absolutely be a contributing factor to the veracity of the outbreaks. Have we succeeded in protecting the vulnerable? Or have we done just the opposite and encouraged physical and mental decline brought on by the very best of intentions? If you look at the optimistic median survival of 2.2 years, rather than the US study of 5 months, that means we have locked away our elderly for almost half of their remaining lifespan. When I asked the public for comment on this bill, I received over 250 responses. I'd like to read you a few of those. My father with dementia is a new admission to Glenridge Nursing in Augusta, March 16th, 2021. His inability to make this transition with his wife and daughters by his side has made this transition extremely traumatic on him and us all. Another, the restrictions placed on loved ones is cruel and inhumane. Interaction with loved ones is essential for their mental and physical well-being. My stepsister has been deprived of this vital support for a whole year and has suffered mentally, physically, and emotionally from this deprivation. It has contributed to her impending death. Please support LD 1139. And her sister has been put on hospice as of 2 days ago. My father was kicked out of the South Paris Veterans Home the day before Christmas. So heart-wrenching. They said that it was because they could not meet his needs. He had become so angry and complained a lot. I say because of no visitation. We could not even go to his window, so he could not see us. The whole thing is terrible. It is still too hard to reason with this. He was moved to Farmington, hours away from family. Another, please God, let this pass. I brought my mom up here from Alabama because she couldn't live alone anymore. She ended up in a nursing home due to a fall right at the beginning of the pandemic, and I haven't been able to give her a hug since she has aged 20 years in that place. She always looks disheveled no matter what time of day I see her. I'm a lucky one. I can do window visits, but she has a hard time holding the phone and she can't hear well. So basically it's just staring at her through a window. It is breaking my heart. My mom was in a care facility. We pulled her and took her home with us because both heels had bed sores, which they kept from us. My husband has Alzheimer's. There's a lot he does not remember, and simple things are confusing to him, like window visits and video calls, but it is clear to him that I have not been there. His health has deteriorated rapidly. It is easy to see. The staff is stressed and needs our help. He has nosebleeds often, but the staff struggles with remembering to turn on the humidifier I brought to help him. And lastly, my grandmother is 94 with progressively worsening vision and vascular dementia. It's been just over a year since we hugged her. She cries when we talk. It's been a nightmare. And I just wonder why her staff is allowed to come and go, but we can't. My bill, LD 1139, seeks to balance protecting our elders from the deleterious effects of isolation while ensuring proper precautions. No matter what situation we find ourselves, residents must maintain the right to stay connected with a loved one. If passed, these guidelines would be in place in the future to guide visitation in any future pandemic. The emergency bill establishes the right of a resident of a long-term care facility to designate a person as an essential caregiver who may visit the resident at the request of the resident at any time and who may not be prohibited from visiting because of an outbreak of disease or other reason. The essential caregiver is subject to the same requirements as employees of the facility, including requirements for illness screening and testing and use of personal protective equipment. The resident of the facility may have only one essential caregiver at any time, and a change in essential caregiver must be coordinated between the resident, essential caregiver, and facility director. I do wish to present an amendment to the bill, such that essential caregiver means a person chosen by either a resident of the long-term care facility or a resident's medical power of attorney. The same would apply when making any changes for a resident with a medical power of attorney. When considering legislation, it's important to ask, what problem does this fix? Here in Maine, we have many wonderful long-term care facilities and caring staff that have worked so hard to support our elders over the last year. Despite that, there remain considerable inconsistencies to their approaches to visitation. Some facilities have allowed family members to take their loved one to doctor appointments outside of the facility throughout the pandemic, while others have not. Some have allowed visitation for hospice residents, while others have limited such visits. Despite the Centers for Medicare and Medicaid Services issuing guidance for visitation in nursing homes during COVID, there has not been a set protocol in our state. It's important to remember when considering this bill that visitation for many residents is not simply a social occasion, but is literally a matter of life and death. In the end, no facility or staff can ever take the place of a family member or loved one taking care of their elder. I'd like to thank my co-sponsors, Representatives White, Evangelos, Fay, Hasenfuss, Morales, Perry, and Warren for their support on this essential bill. I would urge you to listen to the people of Maine and to read their many testimonies. I would welcome a sit down with the stakeholders to improve any technicalities of this bill. And finally, I do have 5 folks who have requested that I read their testimony, and I would ask that I be able to do that after the other Maine residents who have asked to speak to the ought to pass. And thank you. I ask you to vote ought to pass as amended unanimously on LD 1139. I'm happy to answer any questions you might have.
Thank you for bringing that bill forward, Ms. Libby, Representative Libby. Are there any questions? Yes, Representative Griffin.
Representative Libby, did you submit your testimony? I
will submit my written testimony right after this hearing. Thank you.
Okay, perfect. Thank you. Thank you.
And will you be submitting the letters that you're planning on reading, or are they already submitted?
They're already submitted, but the
Okay.
folks that submitted them couldn't be here today, and so asked that I read them.
Okay. I don't see any other questions. I think we'll come back as you've asked. Let's go to Ms. Murphy, Audrey Murphy, if you want to unmute and join us.
I think I know how to unmute.
You got that part right. There you
I'm
go.
holding it down. Okay. Senator Claxton, Representative Meyer, and distinguished members of the Committee on Health and Human Services. My name is Audrey Murphy, and I live in Auburn, Maine. I come to you today to ask and encourage you to vote ought to pass on LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. I want to thank my representative, Laurel Libby, and the co-sponsors of this bill for having the compassion, care, and concern for our elderly population and know what is happening to them is just evil. The cure is much worse than the disease. As Laurel pointed out, my father was in an assisted living home for Alzheimer, but was able to function with assistance. He was 87 years old and was very social. I was his caregiver and I would visit him daily. All of his children would do whatever was needed to make sure his senior years were productive and happy. Then the CCP virus struck. Suddenly, no one visited my dad. In mid-March, my dad fell and was moved from his room he called home to a rehab wing. My dad was in a place that was foreign to him. Not a single familiar face or any of his items from his home were with him. He did not know where he was or what was happening to him. I would try to talk to him on the phone and he would say, "See you on Saturday." It broke my heart to see my once happy and social father unable to understand why his close family members deserted him. I could hear the change in him immediately after we were unable to visit him. He no longer could use the phone or speak to us through the phone or FaceTime. Within 3 months, my dad went from an assisted living to a memory care facility. He died on June 12th. The isolation and lack of family was the biggest reason my father went downhill so rapidly. The facility only allowed one person to be with my father on the day he was dying. By the time my father was unaware that anybody was around him, my youngest sister came from Massachusetts to see him. I gave up my time for my sister to be with him. The facility then said, well, one more person could go in. I again gave up my turn to allow my other sister to go in and see my father on his deathbed. The facility realized that I was not one of the people that visited him, so they made one more exception for me because they knew I was his caregiver and I had been working with them all along. I was able to go in for 1 half hour. They knew he was dying because they told me and come right away because he probably wouldn't make it until 1 p.m. So I went in, gowned up, went into his private room with the door shut, sitting in the room all alone with just him and I. I was only allowed a half hour. Even though they knew he was dying, they came in and said, I'm sorry, your time.
30 seconds, please.
Excuse me? Okay. 40 minutes later, I received the call that my dad had passed away. He died without any loved ones with him. This is cruel and unusual punishment of our elderly. This treatment to our elderly is nothing short of barbaric. No one should have their dignity and respect taken from them. No one should die alone. I feel if you do not pass this bill, the state is committing elder abuse. Thank you for your time, and I respectfully ask that you vote ought to pass on LD 1139.
Thank you, Ms. Murphy. I'm sorry your family went through that experience. Are there any questions of Ms. Murphy? I don't see any. So we'll go now to John Hyatt. Welcome, Mr. Hyatt. When you unmute and join us.
Can you hear me okay, Mr. Chair?
We can.
Honorable members of the committee, my name is John Hyatt of Bangor, and I'm writing in support of LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. I come before you as a son, a healthcare provider, and a man of God. I'm not here in any capacity in regards to my employment as a CNA, BHP, or substitute teacher, or my official capacity as Penobscot County Treasurer or a member of the Bangor School Committee. My late father was a resident of a long-term care facility in Bangor. Every day, my family would visit him for the entire day. For over a year, we would feed him, get him ready, provide all his care. My dad had Lewy body dementia and was wheelchair bound. On March 18, 2020, my family was stopped from having access to him. Nursing homes were closed. I remember standing at the door with my deaf-blind mother, his wife of almost 50 years, begging him to let us in. I remember watching healthcare workers not wearing any PPE and not taking any precautions. Here I am at the front door with N95s, fully gowned up, taking all the good precautions that you're supposed to take, and they were not. This went on for over 2 months. Eventually, we got a doctor to put on hospice. Eventually, we got in to see him. What we saw was shocking. He looked like he had just got out of a POW camp. He hadn't been fed. He had bed sores. My family knew we had to bring him home, which we did. We brought him home, and 25 days later, he went to be home with the Lord. I had been on the front lines during the pandemic. I saw healthcare workers not wearing PPE. I'm a conservative guy. I was out there wearing a mask everywhere. I took all the precautions. I have been in homes where I've been the last person to hold the hand of someone who's making their final trip. All the precautions. In December, I got COVID. Wasn't told that I was exposed to it, got it, and infected 11 family members. We need to allow loved ones in to see those who are vulnerable. My father served this country in the Army, but during this time, that past period, we didn't serve him. I respectfully ask this honorable committee to unanimously pass this bill. Thank you, and God bless you all.
Thank you, Mr. Hyatt. Are there any questions? I don't see any. My condolences on your dad's death.
Thank you, Mr. Chair. Be safe, sir.
You too. I see anybody else in the waiting room who wants to testify? I don't see any. Yes, there are some. Welcome. Let's see here. Beth Jones, would you like to unmute and testify? Welcome.
Thank you. Senator and members of the committee, my name is Beth Jones and I live in Dresden. I ask that you vote ought to pass on LD 1139. Health is such an important consideration in all of our lives, as has been exemplified over the past year. Protecting ourselves and those around us is paramount to the human experience. What we must realize is that health is multidimensional and involves not only the physical, but also the mental, emotional, and social dimensions of who we are. What is best for diverse members of society cannot be defined by one simple set of guidelines. This is particularly true for the marginalized in society, who tend also to be the institutionalized, such as those in long-term care, group homes, and psychiatric facilities. The damage that has been done over the past years to these individuals is nothing short of unconscionable. This is in an undoubtedly noble attempt to protect their physical health. We have disregarded every other dimension of who they are, what they want and need. My father is 74 and diagnosed with dementia. In February, my family went through the agony of my mother having a stroke, followed by my father having a stroke 10 days later, and a 21-day hospitalization from which he was immediately placed in Greenwich memory care. Imagine for a minute you have just watched your wife have a stroke, spent 21 days in the hospital where you were scared as your dementia waxed and waned, and then transported to a facility where you'll spend the rest of your life. The facility does everything they can to make you comfortable, but the one thing you really want and need is to see your wife, hold her hand, and her reassurance you are safe and everything will be okay to help settle you in to make you comfortable. Instead, you are left to make sense of everything alone with some amazing but overworked and understaffed nurses. You are alone in a new room with a bed and your dementia. No love, no reassurance, all in the name of your safety. Now imagine you are his wife, and instead of being able to provide this necessary comfort, love, and transitional assistance, which is considered essential at any other time, you are denied the right to be there. Imagine receiving 5 to 20 calls a day where he is crying and screaming that he is scared. He doesn't know where he is. All he wants is to see you. This goes on for days and now weeks, daily calls of distress and fear. Imagine you yourself having just had a stroke. The emotional toll of listening to this and being separated is destroying your health as well. If you are not in tears from all of this, you should be. This has been my family's reality for the last several weeks. This bill is a common sense measure to prevent this tragedy from ever happening again. Trading one health crisis for another is not justified, disregarding the majority opinion of residents to spend their limited days with someone they love. This bill mandates that strict safety measures as defined by trusted governmental sources be put in place for the essential caregiver just as they are for the staff. This committee surely places its confidence in its fellow governmental safety departments and therefore should be able to confidently assume with outlined measures there is marginal risk to physical health. Please consider our thousands of long-term care residents, including my father, and let them have the mental, social, and emotional support they so desperately need at this time, and vote ought to pass on LD 1139. Thank you.
Thank you, Ms. Jones. Are there any questions, Ms. Jones? I don't see any. Thank you for being here.
Thank you.
I don't see Karen Pelletier. So Lori French, if you'd like to unmute and join us.
Hello there.
Hello.
Thank you. Good afternoon, Senator Claxton, Representative Meyer, and distinguished members of the Committee on Health and Human Services. I am testifying in support of LD 1139. I'm Lori French from Sabatis. My mother, whom I speak of, is from Minot. I want to thank Laura Libby and co-sponsors for helping us help our loved ones. My mother's in a residential memory care setting in Maine, unable to safely keep her home for various reasons, including lack of around-the-clock home care workforce that's reliable. I am one of the many family members who strongly advocate for my mother's care. COVID has made it extremely difficult to do so. My mother has suffered from lack of personal, medical, and mental care during this time. It took a fall and me having to meet my mother at the ER for me to find this out. We were not allowed to visit her residential home, and yet at one point allowed to transport to medical appointments. Things made no sense. At medical visits, I had misinformation from staff, lack of knowledge of changes in health, conditions, and personality, behavior changes, and visits felt frustrating for the doctor and I. These last 12 months, I've had to leave the judgment for my mother's care and well-being to a shift of ever-changing people, new nurses, caregivers, residents, no familiar and comforting faces, and regular input of family. The changes and lack of staff brought less understanding of my mother's personal care, medical, and emotional needs, and increased worry for all. Her likes, personality traits, and preferences lost in the shuffle, set aside in the time of shifts short of staff. In the moment, assistance, family knowledge of prior and current behaviors were lost. When window visits were allowed, they left her anxious, not understanding why we wouldn't come in. Sad, depressed, and withdrawn, she would no longer look out the window. The feeling of isolation and abandonment must have been horrible. Her depression led to lack of caring, more trouble eating and drinking, more physical issues, less cooperativeness, poor sleep pattern, and more tears. Calls into the governor, CDC, and licensing were made, all of them agreeing for social and medical advocacy visits needed to happen. When I became more vocal for requesting outdoor visits that were allowed for nursing homes and assisted living, but blocked by dementia care residential homes, some of our most voiceless and vulnerable, I was faced with phone calls about my mother's care becoming more difficult, and they thought she should go to a nursing home, which is more restrictive environment. No compassion care visits were offered to us, knowing there was a decline. We brought in hospice who assisted in medication changes, care, and visits. She improved. With this assistance, they stopped the talks about moving mom. We believe a family member could have done this just as well. In closing, I'd like to reiterate that if my mother had one person who knew her the best, able to see her in person, advocate better on her behalf, take care of things that were not getting done, she would not have suffered as she has. She would not have had to feel abandoned and forgotten. Her quality of life would have been higher, and possibly the need to bring in hospice and having the conversations about more restrictive and higher level care would have never reached the table as an option. We know in Maine that families tend to take care of each other through the generations. We take pride in our promises to care for one another, whether it be through marriage vows, long-standing relationships in any form, or just out of the pure kindness and love in our hearts. Keeping us out denies us of all that. This bill is a need for our loved ones, as at any time, at any age, we could find ourselves needing this level of care, and we would want this right stood up for. Thank you.
Thank you, Ms. French. Are there any questions? I don't see any. Thank you for being here. Now we'll go to Ms. Seidlinger. If you want to unmute and join us, you're welcome.
Thank you. Good afternoon, everyone. Thank you, Senator Claxton, Representative Mayer, and distinguished members of the Committee on Health and Human Services. Thank you, Laurel Libby and co-sponsors for bringing forth this emergency bill, LD 1139. My name is Lori Seidling and I live in Turner, Maine. I come to you today to ask that you vote ought to pass on LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. Perhaps that should be stated, deregulate visitation. Please help us to be the voices and advocates for our elderly relatives and veterans that have remained isolated, segregated, and denied much needed comfortable inside visits in their private pay or main care rooms in long-term care facilities. My fiance's mom, who I am here advocating for, her exact words, I quote, as she says, crying and shaking, I feel like I am in prison. This is no way for our elder generation or anyone for that matter to live. I would bet prisoners at Thomaston and other jails allow outside and inside visit accommodations for the prisoners. These elderly patients are giving their facilities their entire Social Security check, less a measly $40 for care in facilities that are understaffed, with employees most doing their very best to simply get through their stressful shifts, providing medical and emotional assistance whenever possible. I believe that most of these facility administrators are literally dragging their feet because they do not want families underfoot, policing what is actually going on behind the closed doors under the guise of protecting our elderly from COVID. The facilities bounce you back over to the CDC, who does not return calls. The CDC and the facilities have had a full year to figure out a plan to allow families to have inside visits, to interact, console, and spend critical time that may or may not be left with their loved one's life. CDC and the state of Maine officials keeping these facilities closed down should have many lives lost on their conscience for not focusing on the elderly, many of which simply gave up when they could not see their sons, daughters, wives, grandbabies, and friends. Window visits are not an option on the second floor. Luckily, Gary Ken Stand has all through the winter and does on a daily basis stand outside her window talking to his mom at Marshwood in the cold freezing rain on a cell phone through the window. She has had COVID. If the masks and the social distancing work, open the doors, stop the control.
30 seconds, please.
The depression, isolation, and fever instilled by the media are killing these poor elderly at a greater rate than the virus. Many facilities have very caring staff, but many are spread too thin. They cannot spend time consoling family members when they are responsible for the dozens of patients. We are done with these facilities putting the responsibility on the CDC and higher. Everyone is entitled to quality of life. How inhuman and un-American that we need for our official bill allowing family visits and contact. Whereas residents in long-term care facilities are being denied visits by family and friends, causing a negative impact on residents' mental and physical health. And whereas in the judgment of the legislature, these facts create an emergency within the meaning of the Constitution in Maine and require the following legislation as immediately necessary for the preservation of the public peace, health, and safety. Now, it has been an emergency for months. Do not wait 90 more days. Do you hear us speaking for them? We are done and we demand action. Vote ought to pass on LD 1139 immediately. I pray you let your conscience be your guide when voting. Thank you for your service to the people of the state of Maine and for your time here today.
Thank you, Ms. Seidlinger. I don't see any questions. So now we'll go to Ms. Lundy, if you want to unmute yourself.
Senator Claxton, Representative Meyer, and distinguished members of the Committee on Health and Human Services. My name is Marcia Lundy, and I live in Shapley, Maine. I come to you today to ask that you vote ought to pass on LD 1139 and act to authorize and regulate, visitation of essential caregivers at long-term care facilities. My mother, Eleanor Goodspeed, was a resident at Pinnacle Health and Rehab in March 2020 when the facility became closed to visitors and residents were confined to their rooms. Prior to the lockdown, my sister and I visited several times a week and were able to observe the living conditions and care as well as advocate for her needs. After the lockdown, we were able to only visit through FaceTime calls and occasional outdoor visits under staff supervision, 8 feet apart through a plexiglass barrier, making conversations extremely difficult. COVID-19 was introduced into the nursing home by employees, not outside visitors who were excluded after lockdown. Post-COVID staffing shortages and inability to advocate for my mother's needs resulted in substantial deterioration of her quality of life. She went 6 weeks at one point without a shower. She was provided water to perform her own sponge bath. However, her physical condition and dementia made that nearly impossible for her to do so. When I called the social worker to discuss her living conditions, I was informed that my mother was not necessarily accurate in her perception due to her dementia. However, when she fell and I asked that she be taken to the hospital, I was informed that she refused treatment and that I was not her power of attorney for her medical care. The second time she fell, the nursing home initially refused to transport her to the hospital. The following day, a staff physician called me with concerns over her injury and agreed to bring her to the ER. While in the hospital, she was diagnosed with an acute cerebral hemorrhage and died in hospice care 11 days later. I do want to add that that was probably a blessing, honestly, because my sister and I were with her in hospice. Daily observation by essential healthcare providers during an emergency when there were significant staff shortages would have greatly improved my mother's quality of life and may have prolonged her life by advocating for medical intervention at the time of her first fall. Thank you for your time, and I respectfully ask that you vote ought to pass.
Thank you, Ms. Lundy. Thank you for being here.
Thank you.
Are there any questions of Ms. Lundy? I don't see any, and I don't see anybody else who wants to testify for. So I guess we'll go back to Representative Libby.
Thank you, Mr. Chair. The first testimony that I was asked to read aloud is by Rebecca Martin of Monmouth. My father has been at Togus on the dementia unit since April of last year. We have only seen him through a window or behind plexiglass. My parents have been married 52 years, and it has affected my mom's mental health as well as her physical too. We had no choice to keep Dad home due to his high risk of falling and severe short-term memory loss. They've been wonderful to my dad and have taken great care of him, but watching a disease slowly take him from us is enough. Then you add COVID-19 and it escalates the situation. We were finally able to give him a hug this week, but we can't see the room he has been in. It's still very limited. We are essential family and he needs us as we need to have the time with him before he forgets us or dies. I love you, Dad. Family is everything. The next testimony is from Alex Titcomb of Bowdoin. Senator Claxton, Representative Meyer, and distinguished members of the Committee on Health and Human Services. My name is Alex Titcomb and I live in Bowdoin, Maine. I come to you today to ask that you unanimously vote ought to pass on LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. While I could share with you many horrifying experiences of the effects of the lockdown and resulting isolation on our senior population, I would like to bring your attention to a Centers for Medicare and Medicaid Services report that I have attached. While CMS guidance is focused on protecting nursing home residents from COVID-19, we recognize that physical separation from family and other loved ones has taken a physical and emotional toll on residents. Residents may feel socially isolated, leading to increased risks for depression, anxiety, and other expressions of distress. Residents living with cognitive impairment or other disabilities may find visitor restrictions and other ongoing changes related to COVID-19 confusing or upsetting. CMS understands that nursing home residents derive value from the physical, emotional, and spiritual support they receive through visitation from family and friends. In light of this, CMS is revising the guidance concerning visitation in nursing homes during the COVID-19. I argue that if we are to give up our rights in order for safety, then we are truly less safe. I implore you to learn from this past year, the horror that our seniors have lived through, being cut off from those they love, and to never again allow such abuse to happen in any future emergencies. Allowing one person using the same precautions as staff members into the residence to provide essential care to their loved ones is the least you could do to improve the situation moving forward. Thank you, Alex Tickholm. This is from Wendy Munsell from Livermore, Maine. Senator Claxton, Representative Meyer, and distinguished members of the Committee on Health and Human Services. My name is Wendy Munsell and I live in Livermore, Maine. I come to you today to ask that you vote ought to pass on LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. My thoughts about LD 1139 stem, in part, from my training many years ago as a certified nurse's aide in a nursing home in Western Maine. When I saw the numerous challenges, physical, mental, and emotional, that residents often encountered, I resolved to do what I could to help and encourage the elderly men and women that I cared for during my brief time at that facility. But I quickly learned that all of the kindness, compassion, and competence that I or any staff member could provide paled in comparison to the loving care and presence of a resident's caring visitors. Furthermore, I have seen the difference in care that people sometimes receive, both in the hospital and the nursing home, depending on whether or not they have frequent visitors. Sadly, those without loved ones present to provide companionship and, if needed, advocate for them, often suffer because of their inability to speak for themselves. I've thought of my experience as an aide in that nursing home many times during this past year. My heart breaks for the men and women who have had the heavy burden of isolation from their family and friends added to their already challenging lives. It is truly awful to contemplate the devastating effects of forced isolation on one of our nation's most vulnerable populations. Thank you for your time, and I respectfully ask that you vote ought to pass. Senator Claxton, Representative Meyer, and distinguished members of the Committee on Health and Human Services. My name is Kristen Tripp, and I live in Gardner, Maine. I come to you today to ask that you vote ought to pass on LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. Yesterday afternoon, I spoke with a dear friend who had lost both her husband and her sister over the last 6 months. We talked about life without them and her grief. One point that she came back to repeatedly was the circumstances of her sister's death. Her sister had been a nursing home resident, steadily declining from Alzheimer's. Prior to COVID, my friend had regularly visited her sister, providing loving care and a sense of familiarity to her. With the lockdown, my friend had been prevented from seeing her. While my friend expressed her own grief at being separated from her sister in her last days and months, she also grieves over what her sister's experience must have been. While her cognizant understanding was limited, she certainly must have suffered from the lack of familiarity and routine and a sense of abandonment. Humans are designed for relationship. Without it, we suffer. We know this innately. Premature babies fare better when given skin-to-skin contact. Inmates are given solitary confinement as a more severe form of punishment. Individuals restricted from human contact suffer both mentally and physically. This has been proven scientifically substantially. The family members currently being kept away from their elderly loved ones certainly understand the potential risks associated with COVID and have no desire to harm their parents and grandparents. They have a vested interest in taking care of reasonable precautions, such as staying home if displaying any symptoms, taking their temperature before entry, and washing hands to protect their dear loved ones. While individuals in nursing homes receive, hopefully, caring physical care from the staff, it can't come close to replacing the decades-long relational bonds between residents and their family members. This past year has taken a great toll on the nursing home population in our state. Many are declining more rapidly, both mentally and physically, as a result of being separated from their families. Family members grieve, knowing their loved ones died alone. The measures taken to prevent harm should never inflict greater harm than what they are intended to prevent. While locking down nursing homes was originally well-intended, it has now gotten to the point of inflicting harm on those it was intending to protect. Maine's elderly deserve better than isolation in their last years. It is time to responsibly reunite them with their families. Thank you for your time, and I respectfully ask that you vote ought to pass. And the last one. Senator Claxton, Representative Meyer, and the distinguished members of the Committee on Health and Human Services. My name is Ingrid Lavasser, and I live in Windham, Maine. I come to you today to ask that you vote ought to pass on LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. Some years back, my mother was in a nursing home for 7 years with advanced Alzheimer's disease. I visited weekly with my 2 young daughters, and my sister visited daily on her way to work as a pharmacist at a hospital in Portland. My mother could not communicate her needs. She could barely speak, and she couldn't walk. She did, however, comprehend what we were saying up to the end of her life. She recognized my sister and I, as well as her granddaughters, and she lit up when any of us entered the room. Last year, when the lockdowns at nursing homes and assisted living facilities began, I was privately grateful that my mother had already passed. I can hardly imagine the agony my entire family would have felt to not have contact with our mother except perhaps through a window. We depend on touch and play, tossing a small stuffed bear back and forth to connect with her. To take away the loving touch and sight of family is cruel beyond all measure. The people who work in elder care are angels on earth. Their compassion for the elderly seems boundless. However, they are not family. It is not the same connection. For the sake of the mental and emotional health of our elders who can no longer live independently, I urge you to vote ought to pass on LD 1139. Thank you for your consideration. Thank you.
Thank you, Representative Libby. Are there any questions related to those letters? I don't see any. So we'll go, I don't see anybody else testifying for. So now we'll go to against and hear from Molly Bogart and then Mr. Erb.
Good afternoon, Health and Human Services Committee. My name is Molly Bogart, and I'm the Director of Government Relations for the Department of Health and Human Services. I am reading the testimony of Bill Monteo, who's our Director of Licensing and Certification, who couldn't join you today, but he can be available for the work session, and I will do my best to answer your questions once I read his testimony. So Senator Claxton, Representative Meyer, and members of the committee, I am not Bill Monteo, but reading his testimony, he's the Director of the Division of Licensing and Certification at the Department of Health and Human Services. And I'm here today to speak in opposition to LD 1139, an act to authorize and regulate visitation of essential caregivers at long-term care facilities. And I'm offering the following information for your consideration. The Federal Centers for Medicare and Medicaid Services, CMS, regulates nursing homes, and the state regulates assisted housing facilities. My office, the Division of Licensing, has investigated hundreds of complaints and answered nearly as many requests for guidance regarding visitation. LD 1139 would codify a position of essential caregiver, giving that person greater visitation rights with LTC residents and other visitors would have. While visitation is critical, this proposal directly contradicts guidance from CMS. Thus, the state would not be allowed to enforce this action in facilities that receive federal funding. Using the best medical advice, CMS has released no fewer than 6 guidance documents related to visitation in long-term care facilities and has stated that their guidance governs all visitors, not just those who would have been categorized as essential caregivers. Additionally, there are some significant problems and issues that are not addressed in LD 1139, specifically who determines who an essential caregiver is. I recognize Representative Libby has presented an amendment to that effect. We also are concerned about when conflicts arise, who will be the arbiter. If an essential caregiver does not follow rules, what is the process to revoke that designation, and others. The pandemic has redoubled our efforts to ensure that facilities have the capability to meet their obligations to residents, including residents' rights and visitation, and we have adequate measures to ensure that this access is granted in a safe and responsible way. Thank you for your time and attention, and I would be happy to answer any questions you might have. I think really the most important point here is that this proposal would put facilities in a position of either violating CMS guidance, which could put their licensing in jeopardy, or violating state law. And I don't think any of us want to put facilities in that position. I appreciate all of the stories that we've heard today. I know it has been an incredibly difficult year for people across the state, and especially folks in long-term care. But we have concerns about this as proposed.
Thank you, Ms. Bogart. And any questions of Molly? I don't see any, so welcome back, Mr. Erb.
Afternoon, Senator Claxton, Representative Meyer, members of the committee. My name is Rick Erb. I'm the president and CEO of Maine Healthcare Association. We represent nursing homes and assisted living facilities, testifying today in opposition to LD 1139. But I want to be clear from the outset that our association completely and sincerely understands the needs for our residents to be reunited with their young ones. We especially sympathize with families who have lost loved ones during this very difficult time. We share the goals of reducing isolation and facilitating visitation, thereby improving quality of life for long-term care residents. The impact that COVID-19 has had on our population has been disproportionately unfair. As difficult as this year has been with vaccination and adherence to strict infection control guidelines, we are turning the corner. In fact, we are slowly but surely reopening our facilities after getting the green light from federal and state government a few weeks ago. We are doing so carefully and thoughtfully and safely. This bill, albeit well-intentioned, is worrisome to providers who are working diligently to prevent COVID-19 from entering their facilities. This bill would allow multiple visitors at any time throughout the facility with no regard for roommate privacy or preference. Although it says facilities may restrict essential caregiver contact with other residents, it is unrealistic to expect that this would be managed or monitored effectively for every resident at any given time. Considering that most of our rooms are semi-private, the potential for contact with other residents is great, which increases risk. The bill allows essential visitors at any time, regardless of Maine's county's positivity rates, and allows for continued visitation in an outbreak situation. This is in direct conflict with regulations and evidence-based practices in regard to infection control and visitation. We also question allowing untrained caregivers to provide ADL care, which is reserved now for certified employees. It is not specified in the bill who is responsible for essential caregiver behavior, competency, or what happens if a resident is harmed. We are aware of similar programs in other states, but they are voluntary and utilized early on during the pandemic. As we continue working towards the goal of fully reopening our homes, we believe this type of program is unnecessary. MHCA continues to collaborate with stakeholders such as Maine CDC, DHHS, the Long-Term Care Ombudsman Program, to bring visitation back to pre-pandemic levels. For your information, I have included an excerpt from the visitation guidelines from the Center for Medicare and Medicaid Services. I won't read it, but it illustrates the conflicts between the current rules in this bill. Our home's ability to prevent or mitigate COVID-19 are based on adherence to public health and safety guidelines created by experts. We cannot support legislation that undermines that, but we can keep working to achieve robust visitation and reopening. We know how important this is. Thank you for the opportunity to comment. Happy to answer questions if you have them.
Thank you, Mr. Erb. Are there any questions? Mr. Erb, yes, Representative Connor.
Thank you, Mr. Chair. And thank you, Mr. Erb. I missed you in the last testimony, so I'll get you on this one if you don't mind.
Very good. Very good.
I have two questions, if you don't mind, Mr. Chair. The first one is, in most facilities, how many caregivers, whether they be CNAs or nurses, how many residents does one caregiver usually interact with on any given day?
I'll start by telling you what the minimum ratios are, but I would point out that facilities almost always are above the minimums, particularly in times when it wasn't as hard to staff. But the minimum is one staff person per 5 residents in the daytime hours, 1 to 10 in the evening hours, and 1 to 15 overnight.
So one caregiver could see potentially 10 different people in a day, but your testimony was worrisome that one individual coming in could see just, their person they're coming to see, and then maybe a handful of others. So I was just curious with that. My second question is, what makes Maine unable to do what other states have done? You had mentioned other states have done this on a voluntary basis. Is there anything precluding Maine from doing something similar?
On a voluntary basis, I believe we could. I do want to point out it is a very small number that have implemented this. I don't want to give the impression that this is common by any stretch. I can get more information for the work session, but we're talking about a handful.
Okay. Thank you very much. I appreciate your answers, and thank you, Mr. Chair. That's all I have.
Sure. Representative Javner.
Thank you very much, Senator Claxton. Thank you, Mr. Erb. I have just a couple of questions. So and first of all, I really want to thank you, Mr. Erb, for working towards the goal of fully opening these facilities. As we've heard today, it has been excruciatingly painful, what we've been through. So in your testimony, you make a statement that says you don't believe that this type of program is necessary. I really would appreciate if you could expand on that statement a little bit after hearing everything that we have today. Hindsight is, of course, always 20/20, but how is it, that a program such as this is unnecessary after what we've heard today?
Well, what I'm referring to is most recent guidelines from CMS, which have been taken by our own DHHS and put into regulation. There is much more openness now, and we are steadily moving in that direction. The biggest problems that we faced were at the beginning of the pandemic, and much of this because COVID-19 was very different than any infection control that we have had to deal with in the past. The fact that such a high percentage were asymptomatic created many more problems than we have seen before. The high mortality rate of COVID-19 was a very difficult situation for everyone that had to deal with it. What I am referring to is that we are making progress, and the very high vaccination rates that we have been able to achieve, particularly among residents, and the changes in CMS guidance, I think have made a big difference.
If I may, Chair.
Sure, please.
Thank you. So what are those opening guidelines as of now that our facilities have?
These are the guidelines that you have seen that do allow more visitors. They allow physical contact. In order to answer that fully, I'd like to get those for you, and before your work session, I will have those for you.
Thank you very much. I would appreciate that greatly. Thank you.
Just to be clear, Mr. Erb, are you referencing the CMS updated guidelines from March 10th?
I believe that's the date.
Yeah, okay. Okay, thank you. Are there any other questions? Yes, Representative Connor.
Thank you, Mr. Chair. This is my last one, I promise, sir. Mr. Erb, again, I definitely want to say that I appreciate everything you brought forth today. One of my concerns, and one reason why I particularly like this particular bill is because it will address something in the future. We all know that given this pandemic, that it could all intents and purposes happen again. So I would like to see something like this put forth so that in the future, we have something to go off of. We have mechanisms in place to help our vulnerable. God forbid it ever happens again, but if it does, I would like to see something in black and white that we can fall back on versus just saying we're opening up our facilities now. We don't really need this bill because people can start, seeing their loved ones. I'm trying to look down the road a few miles and hopefully address that. So I know it's not a question, but I just wanted to get that out there for you, sir.
Thank you. And I can see I see validity in what you're saying. If I have a concern with it is we did not know what we would be dealing with COVID-19 coming into it. No one had experienced anything like it. I would be concerned about trying to make black and white judgments now about what a future pandemic or whatever other emergency situation we are dealing with. We may not have that luxury of making decisions in advance until we know what the circumstances are.
Thank you, sir. That's all I have, Mr. Chair.
Thank you. I don't see any other questions. So as I understand it, that concludes our testimony against this bill. And we have one other person to hear from who's neither for nor against, and that would be Ms. Thorson. Welcome.
Thank you. Senator Claxton, Representative Meyer, and committee members, my name is Patricia Thorson. I am the Ombudsman Program Manager, and the Maine Long-Term Care Ombudsman Program is a statewide nonprofit organization that provides advocacy for older adults and adults with disabilities who receive long-term services and supports in all settings. Early in the pandemic, the Centers for Medicare and Medicaid Services issued guidelines for visitation in nursing homes across the country with the goal of the protection of residents who, as you know, are at a great risk if they contract COVID-19. All nursing homes must comply with these guidelines. We know that the restrictions in visitation of residents in long-term care facilities over the past year has been extraordinarily difficult for both residents and for their families. The Ombudsman Program received calls from families every day with questions and concerns regarding their separation from loved ones. These calls continue. Spouses married over 60 years, suddenly separated by the pandemic, children of residents with dementia who worried that their parent would not understand their absence, families who had previously been able to visit daily have been concerned about whether their loved ones' needs would be met. We have worked with these families to find ways to help them remain in contact and, when possible, to facilitate window visits, outside visits, and compassionate care visits. We are a resource for residents and families who need our help. From the beginning of the restrictions, the Department of Health and Human Services, Division of Licensing and Certification, the Office of Aging and Disability Services, Maine CDC, Maine Healthcare Association, and the Ombudsman Program have worked together diligently to provide education and support to families and providers regarding the CMS guidelines for visitation, and these efforts continue. Fortunately, there are revised guidelines for visitation in nursing homes that were issued March 10th, 2021, that allow for inside visitation, and fully vaccinated residents may have close contact with visitors as long as the residents and the visitors perform hand hygiene and wear masks. CMS continues to emphasize that facilities shall not restrict visitation without a reasonable clinical or safety cause. CMS also notes that they do not distinguish between essential caregivers and other visitors. Nursing homes must comply with CMS guidelines. State laws that mandate a different requirement for visitation would put nursing homes in the position of being in conflict with either federal rule or Maine law. Every effort is being made to provide outreach to residents, families, and providers to provide education regarding the new visitation guidelines. We're working with the Maine CDC, the Division of Licensing and Certification, Maine Healthcare Association, and Leading Age, Maine and New Hampshire, to hold a webinar on April 15th at 3 p.m. on the new guidelines. Thank you for your consideration.
Thank you for that information, Ms. Thorson. Representative Connor? Nope. I
Nothing
don't
from me
s-
today. Right?
Okay, Representative Madigan.
Thank you, Mr. Chair. Thank you for being here, Ms. Thorson. As a social worker, I've been concerned about the effect of isolation on people in long-term care facilities. And I feel like I wish I had a dime for every time I've said in the past year that no one's having any fun. But I wonder kind of whether your office has some specific information about the mental health effects of isolation and whether that is something you could bring to the work session.
Certainly, yes. I mean, we certainly have heard, as I said, from many families and residents every day, but there's also information that's put out by the National Consumer Voice, and we could certainly bring information for you on the impact.
Thank you.
Representative Javner?
Yes, thank you, Senator Claxton. Ms. Thorson, so with these new guidelines that have been issued March 10th, are these still voluntary?
No.
Or
no.
Okay, so every facility then across the state should be working according to what these new guidelines are.
Yes.
Thank
They so they're for nursing homes, I'm sorry, and then the main DHHS has adopted those for also for assisted housing facilities. So for residential care, PNMIs, assisted living.
Adapted them so they're not the same.
So they're fairly similar. I mean, there's some differences, but they do have, and that can be brought to the work session, certainly their guidance that they've given for assisted housing.
Great, thank you.
Mm-hmm.
Yes, Senator Moore.
Yes, thank you for being here, Ms. Thorson. Do we know of any other states maybe that have a similar policy, such as this bill that's being proposed?
Yes, as Rick Erb said, there are, I think there's like 6 states that did adopt or have some legislation around essential caregiver. I think they're all different. They all look different. And I'm not sure how the states are managing those programs. We can certainly gather that information for you.
I think that would be helpful for the work session. Thank you.
Mm-hmm.
That might be available at some place like NCSL or CSG. Maybe they've compiled that somewhere, so you don't have to do original research. Are there any other questions? Senator Moore, you're all set? Okay. So I don't see any questions, and I appreciate you being here, Ms. Thorson. So that'll conclude the public hearing portion of our consideration of LD 1139. Thank you to Representative Libby for bringing it forward and for the folks who are here to testify. So we have 2 more bills to hear, and one of them is from Representative Lemelin. And yes, Representative Meyer.
Thank you, Mr. Chair. Just going back to 1139,
Sorry.
as far as information from our analyst, I would like to know the percentage of Maine COVID deaths that are from long-term care nursing facilities.
Okay, as I was saying, thank you, everyone. Are there any other questions for our analysts as we finish up? Yes, Representative Javner.
Thank you very much, Senator Claxton. Yes, I'm very interested in the terminology that they're utilizing here as essential caregiver in the bill. And there has been some concern over using that term. So how else are we going to be able to describe this? Also, there was an amendment that Representative Libby brought forward about having it as a medical power of attorney as well. And if we could just get even just a definition of, what that medical power of attorney is, according to what this bill is asking for. Thank you.
All right. Any other asks of Anna? Now I don't see any. Okay. So before we get to the last 2 bills, I'd like to take a 5-minute break, get up, move around, And we'll be back here. It will make it 6 minutes, 3:36, 3:38, 3:38. Oh, we want to make it, let's make it 3:40. 3:40 will make it 8 minutes. Take care. See you then. Can everyone hear me? I had to ditch the headphones. All right, so we can get started again. This is a continuation of the Health and Human Services Committee's work on a number of bills this afternoon. We have two more to hear. We'll go to LD 1001 and hear from the sponsor. Welcome.
Thank you, Senator. Senator Claxton, Representative Myers, and distinguished colleagues of the Health and Human Services Committee. I am Michael Lemlin, and I represent District 88, Chelsea, Jefferson, Whitefield, and part of Noblesboro. I'm here today to present LD 1001, an act to ensure parents access to their minor and adult children with disabilities when in a healthcare facility. Regardless of the situation, unless the child or adult does not want the parent present for personal reasons, a parent or guardian should always have access to their special needs child or adult when admitted to a hospital or healthcare facility. In the case of individuals with special needs, many cannot communicate effectively, especially except to a parent or guardian. My son communicates well with American Sign Language. However, the context of his sign language is mostly known to us. When a person with disabilities is nonverbal, they still have the ability to communicate with their parent or guardian. These individuals also have the right to have a person they know and trust by their side in a time of confusion and fear, or they may become frantic and disoriented. In hospitals and care centers, if hospitals and care centers can provide a safe way for their staff to be with the individual, then they can also provide a safe way for the parent or guardian to also be present. Millie Coombs is the reason for my bill. I saw her on the news in November. Millie's adult daughter was admitted to Maine Medical Center, and Millie was astounded to find out she was not allowed to be with her daughter, who could not communicate with staff and was very frightened. This was devastating to Millie and her adult child. Millie wanted to be here and tell her story. However, she is with her daughter getting dialysis. The ADA has provisions which are intended to help in these situations. However, it could take days or longer to contact the ADA and get them to resolve an issue. Also, we do not need CDC guidance to establish standards for safe visitation because, like I said, if a nurse or doctor can be in the room, a parent or guardian can be told how to use PPE properly to also enter the room. It is much easier to safely admit a parent than a hospital is indicating. So I ask you to please consider LD 1001. Thank you.
Thank you, Representative Lemlin, for bringing that forward. Are there any questions for the representative? I don't see any. I noticed there are some support testimonies, but nobody here has signed up apparently to testify for. So now we'll go to folks testifying against. That would be Jeff Austin. If you want to unmute and join us.
Good afternoon, Senator Claxton, Representative Meyer, members of the committee. My name is Jeff Austin. I'm here on behalf of the Maine Hospital Association to speak in opposition to the bill. Let us be clear at the outset that having family members with patients benefits hospitals in almost all circumstances, particularly in the circumstance described by Representative Lemlin, where the patient is either agitated and or lacks the ability to communicate clearly. It is in the clinician's interest to get clear communication. It is in our insurance provider's interest. It is in our financial officer's interest who doesn't want to see an unnecessary readmission. There are lots of people throughout the building who want family members present. They are helpful to us. In extreme cases, such as COVID, it can be very difficult to allow for that. It's somewhat easier to say, well, can't they just be given the same precautions as the clinicians as they treat the patient? If it's a COVID unit or a ICU COVID unit, the precautions there are quite extensive. It is not simply masking and washing hands. These are full body gowns and suits. And by the way, if you remember, at the time, a year ago, they were extremely difficult to come by. And we were in a situation of potentially reusing masks, sterilizing masks. It's in hindsight or with time, some of the stress level abates. But I remember it a year ago and the worldwide searches for qualified protective material. I think the restrictions have eased today as compared to even a year ago, even though infection rates are higher, because we know more about how to manage the risk. This bill is not going to address so much this issue as the next one. And we don't know what the next one will look like. In asking you to reject this bill, we understand what we're doing. We're asking you to trust us. But that's why I started where I did. So many groups in the hospitals, from the discharge planner to the clinician to the financial officer to the risk manager, recognize the benefit of having a caregiver there who can significantly aid us in providing the care. It is only in situations of extreme danger that we don't. And it is not just about that particular patient or that family member. It is about everyone in the facility. So I'm a parent of 2 children. If my children were in the hospital, I would be extremely upset not to be able to visit them. When we discussed this, we had a CEO on the call whose own parent passed away and did not yield his own facility's rules for his benefit. He was not with his father at the time he passed. We recognize, and some of our members have even personally felt these difficulties, but in keeping us away, others are being kept away, and we hope the facility is being kept safe. In a way, I'm glad we're talking about this bill and not some other bill about how to stop rampant, massive outbreaks in hospitals and why we didn't do better to save patient lives. I'm glad this is the bill we're fighting over and not that bill. So I respect Representative Lemlin and where he's coming from. And as a parent, I certainly understand it. We don't undertake this lightly, but we do think we should not try to think we know what's going to happen in the next pandemic and that you can pass a law that will safeguard everyone. With that, I'd be happy to take any questions.
Yes, Representative Connor.
Thank you, Mr. Chair. Thank you, Mr. Austin, for being here. I believe the sponsor mentioned it and you referenced it as well. Looking at it in the eyes of the parent or the guardian coming in as a care provider, having to don all of the same paraphernalia. My question is, why do we not look at the caregiver or the parent coming in the same as the patient? The patient that's coming in is not coming in donning all of the full gear. The patient is not coming in, in full protocol. But yet nobody says that we can't bring the patient in, even though we're in COVID times. So why can we not treat the parent or the guardian the same as the patient who is in, the COVID unit or wherever they are, and allow that interaction to still take place? I was just curious if you could answer that.
Right. I think I'd give it a couple answers. I mean, the quick answer is, if you recall, at the outset of the pandemic, we even stopped bringing in patients. The governor's directive to cease surgeries that could be postponed. So we weren't just keeping family members out. In some cases, we were keeping patients out if the care was something that could be scheduled for later. Obviously, in some cases, you can ask the patient to don a mask. If it's a broken arm, you can give them a mask, you can give them some protective equipment. But there are other situations where you need access to the patient in such a way that you can't, if they need a breathing tube or a feeding tube, I mean, you just can't prevent all, you can't take all precautions with the patient because you need to get hands on the patient to care for their needs. But where you could, they had a broken toe, you'd put them in a mask and you would take some of those precautions. But because the patient can't be protected, everybody else has to be.
Thank you. That's all I have, Mr. Chair.
Thank you. Are there any other questions for Mr. Austin? I don't see any. Thank you for being here.
Thank you.
Now we'll hear from Laura and Willie. Did I make a mess of the last name?
No, you've pronounced it perfectly. Can you hear me okay?
We can.
Great, thank you. Good afternoon, members of the Committee on Health and Human Services. My name is Lauren Willie. I am an attorney with Disability Rights Maine. As part of our work at DRM, we assist people with disabilities with reasonable accommodations, either through education, technical assistance, and at times directly representing clients. Under the Americans with Disabilities Act, as well as other specific state and federal legislation, people with disabilities must be reasonably accommodated by entities such as hospitals to allow them to access services to the same extent as people without disabilities. This could include allowing caregivers to accompany them in hospitals to provide support, even if the hospital has a policy that otherwise disallows it. Under the ADA, a person can request such an accommodation, and then the hospital is required to consider it and to engage in what's called the interactive process to ensure that individualized plans can be developed in a way that ensures safety and directly addresses the concerns raised. We have specific concerns about this bill, and that it is too general in addressing concerns about access. The bill does not, for instance, in any way define what would constitute a quote person with special needs, nor does it appear to consider the wishes of the person who was admitted to the hospital. As drafted, it would also appear to permit parents of adults with special needs to be allowed access to the person, even if they're not guardians or even if the person themselves object to that access. Throughout this pandemic, we have had concerns about our clients being denied the support that they may need at hospitals and other facilities. We definitely understand the frustration that's underlying this bill. In our experience, we've found that education and advocacy based on the Americans with Disabilities Act is the most effective means to allow for personalized accommodations for people with disabilities who are hospitalized. To that end, we've developed resources such as an online training on reasonable accommodation requests that's available on our website. We've developed a forum that we've given to people to help them know how and when to ask for a reasonable accommodation. That form's also available on our website. So we found that sort of thing very effective. And so in our position is really that the Americans with Disabilities Act is really sufficient to address these concerns. So for the foregoing reasons, we'd urge the committee to vote ought not to pass on this bill. I'm happy to take any questions if anyone has any.
Thank you, Ms. Willie. Are there any questions? I don't see any. Thank you for being here.
Thank you.
Now we'll hear from Lisa Harvey McPherson, who's already unmuted. Thank you.
Yes, good afternoon, Senator Claxton, Representative Meyer, and committee members. My name is Lisa Harvey McPherson, and I'm here to speak in opposition to this bill on behalf of Northern Light Health. And the focus of our opposition is the bill lacks the context of CDC guidance for infection control measures during what we currently have as a pandemic, but we certainly have other infectious outbreaks, such as flu season. Before the pandemic, if we were implementing our procedures to restrict visitation, it was very often because we had an epidemic of influenza in the state of Maine. Our visitation policies account for allowing for visitors, and I want to talk a little bit about when visitors are ruled out. Our policy states that if a visitor comes to the facility and is screened for symptoms of COVID-19 and shows positive in terms of those symptom screens, they are not allowed to visit a patient in our facility. If a visitor comes to our facility and they've been instructed to quarantine because of out-of-state travel, or they've been exposed to an individual with COVID-19, they too are not allowed visitation in our facility. When a patient has COVID-19 or is a patient under investigation for COVID-19, our standard policy is those individuals are not allowed visitors. But like Jeff said, we absolutely understand and acknowledge and want to engage visitors when they are an integral part of that patient's care. So when we have a patient with COVID-19 or what we call a PUI, a patient under investigation, and there's a request for visitation, then the senior nursing leader in that facility can look at the unique circumstances of that patient and authorize that visit, providing that visitor meets the screening, does not need to be quarantined, and then we in turn implement all of our protocols to protect both the patient and the visitor. We have specific visitation policies that relate to COVID-19, but they're pretty similar to when we have an influenza outbreak. And we allow visitation for end-of-life care, obstetrics, pediatrics, pediatric ICU, natal ICU, ED, trauma, surgery, procedure room, adult inpatient. And then we have visitation for disruptive patients when the visitor is essential. And we have visitation for incapacitated, altered mental status, or developmentally delayed patients. By and large, those groups are allowed one or on a very limited basis, 2 visitors for a period of time. You've had a lengthy discussion about nursing homes. This bill referenced nursing facilities. So I attached to my testimony nursing facility guidance for indoor visitation when there's an outbreak in the facility, and other additional visitation recommendations for that type of facility setting. And with that, I'm probably at my 3 minutes. And so I welcome any questions that you have.
Thank you. Are there any questions? Yes, Representative Craven.
Thank you, Mr. Chair. Thank you, Lisa. Are those standards that you have in place, are all of the hospitals complying with those? Is that how they, for example, if somebody has autism and they're very uncomfortable and they are very stressed and permission is requested, does any of all of the hospitals allow a parent or another person that they know to come in and be with them?
We develop our policies based on CDC guidance. Now, do all policies, hospital policies, look the same? That's something that Jeff can certainly ask of the Maine Hospital Association members. But my sense is we were all learning about this and sorting this out together, and there was a pretty liberal sharing of policies and procedures when we were all developing all of this. And I know the CMOs, particularly of the health systems, met with CDC directly. So I think there's a fair amount of standardization. Is it 100%? We can certainly look at that.
Yes, Representative Connor.
Thank you, Mr. Chair. And thank you, Ms. McPherson. Very quickly, irrespective of COVID, I was just reading through this bill. This bill doesn't mention COVID or any pandemic whatsoever. It just says during a state of emergency, parents or guardians of children or persons with special needs who are admitted to hospitals or care facilities should have access. Can you elaborate on any particular instance that you can think of, again, irrespective of COVID, of when a child or somebody with developmental disabilities would not be allowed to see their parent or guardian?
The best example I have, now when we have an influenza outbreak in the state, it's not an official emergency, but there's a general declaration that there's an influenza outbreak. And before COVID, that would be the time most commonly that we would restrict visitation. So what we would do would be to screen for signs and symptoms of the flu. And if a parent or guardian was exhibiting symptoms, then in that case, I anticipate that we would restrict visitation.
A follow-up, Mr. Chair?
Please.
So why, just curious, you used influenza, so you screen the parents, and if they are clear, you allow visitation. could that same principle not play out with COVID if the parents or individuals have not displayed any of the symptoms or have even been tested and show negativity?
That's exactly how we do it. So we screen them when they when they come to the hospital. We ask them a series of questions, and it's the same questions that we ask of all our staff. And if they respond positively to any of the questions that are signs and symptoms of COVID, then their visit is restricted. And if they are directed to quarantine because they've been out of state, which is less so now, but early on, if they've been out of state, or if they have been exposed to someone with COVID, then they are restricted. And those are the same standards that we use for our staff.
Thank you. Thank you, Mr. Chair. That's all I have.
Sure, sure. I don't see any other questions, so thank you for being here, Ms. Lisa Harvey McPherson. And we'll move on to Mark Parker. Is that Dr. Parker?
Yes, thank you. Thank you, Senator Claxton, Representative Meyer, and members of the committee. I'm Dr. Mark Parker. I'm the Vice President of Quality and Safety at Maine Medical Center, and I'm here to testify in opposition to LD 1001. I personally am a kidney specialist for over 25 years, and I'm also the hospital patient safety officer who has guided a lot of the management of our visitor protocols during the COVID-19 pandemic. And I'm also the parent of an adult son with a learning disability, so I thoroughly appreciate the position of advocates for this bill. Our care team members are focused on providing care to our patients that accelerate recovery. We recognize that family support is critical to improved health outcomes, and in cases where patients have special needs, it is critically important to involve family and caregivers and recognize the vital support that they provide. And truthfully, our approach is aligned with providing this access support whenever it's safe and feasible. During the pandemic, hospitals have been required to meet US CDC guidelines related to patient and care team member safety. With this in mind, we've worked diligently to safely facilitate visitors for patients with special needs since the start of the pandemic, even when there was very little known about the virus and PPE was scarce. And in the limited number of unique circumstances in which the presence of family will not facilitate care and may hinder workflow or could endanger the safety of the patient, visitor, care team, or our community, we've facilitated other means of communication for a patient and family, including Zoom and telephone. So I'd like to share one quick story with you. I recently cared for a patient with developmental disabilities who was severely ill and also COVID-19 positive. And while critically ill on multiple forms of life support and deeply sedated, he had no meaningful awareness of his surroundings. He was cared for in our COVID-19 intensive care unit, which has a very tight workflow due to the amount of equipment that's used to care for these patients and the necessary PPE like powered air purifying respirators or so-called PAPRs that is critical to ensure the safety of our care teams. In this situation, the risk of allowing a visitor in the patient's room outweighed the benefits. The visitor would have needed specialized PPE that they were not trained to use and also might have physically impeded care in a restricted environment, placing all involved at risk. So let me be clear, these decisions are not made lightly or by one person. At Maine Health, we employ consensus decision-making that involves the clinical care team that includes the patient's physicians and nurses and hospital administrators with clinical experience. And then we work with our families. In this case, I had the, thank you. I had the unique perspective of being both the patient's provider and a hospital administrator. So I would say the legislation before you today will strip clinical administrative teams of the latitude to make this decision in which we balance patient benefit and risk to the patient, visitor, care team, and community. It would also place us in the most difficult position in which we are stuck between adhering to US CDC guidelines and licensing regulations and state law. I would also note that today we're considering this legislation with COVID-19 in mind, but we must consider that we may treat other highly contagious diseases in the future, including, as an example, Ebola. I urge this committee vote ought not to pass on LD 1001, and I thank you for your time and consideration, and I'm happy to answer any questions.
Thank you for your testimony. Are there questions of Dr. Parker? I don't see any, sir. Thank you for being here.
Thank you.
So that concludes the testimony against. I don't see anybody here to speak neither for nor against. And that will then conclude the public hearing portion of consideration of LD 1001. Are there questions or information you'd like to have available for the work session that we could direct to Anna? I don't see any. So we'll move on to the last bill, which is LD 1148. I see that Representative McCreight is here, and she'll be introducing the bill. When you're off mute and ready to go, we're ready for you.
Thank
Welcome.
you. That is so weird, that ozone you go through. It's like,
Yes.
am I gonna make it? Hi, everybody. Thank you. Senator Claxton, Representative Myers, distinguished members of the Health and Human Services Committee. I'm Jay McCreight, representing Harpswell, West Bath, and Northeast Brunswick in the House. I'm here today to present LD 1148, a resolve to increase broadband access in private non-medical institutions. The Consumer Counsel System of Maine, or CCSM, identified a significant problem affecting residents of private non-medical institutions, or PNMIs, and asked me to submit this proposal. I was happy to do so because we know that a basic human need is connection with others, and certainly you've been hearing many bills on this issue today. The pandemic has highlighted the importance of connectivity, but lack of access by residents of PNMIs to this important tool isn't unique to this time of pandemic. It has just been made more visible. This resolve is offered to help improve the ability of residents of PNMIs to access high-speed broadband where they live. This is a quality of life issue. Broadband access opens doors to the world, allowing us to be connected with family and friends, to participate in recreational activities, to seek out information and education, to receive medical and behavioral health care through telehealth, and to connect with spiritual and religious communities. Residents of these private non-medical institutions are extremely limited in funds available to them to cover the cost of their personal needs. These funds certainly aren't sufficient to cover the cost of monthly broadband fees. The resolve before you proposes that the department determine how best to make sure that high-speed broadband access is available at no cost to residents at all levels of PNMIs. An exception, of course, would be those where broadband access doesn't exist, something the whole state is working on. I suggest, though, that when it does become available, it would be clear that these residents would also have access at no cost. Thank you for your attention, and I'll do my best to answer any questions.
Thank you, Representative. Are there any questions of Representative McCreight? Yes, Representative Craven.
Thank you, Mr. Chair. Thank you, Representative, for bringing this forward. I just wonder why those organizations don't have broadband, Wi-Fi, or whatever, just to do their own work, and how come that can't be expanded for residents to use?
Yeah, I agree with you. I think, to me, that would be the simplest solution. And for the department, these would be organizations with DHH oversight. So working with those institutions to require that, most of them would have it. If not, I don't know, if not all of them. So why wouldn't they extend it to the residents as well? I have the same thought.
I just have a follow-up. So I guess I'm wondering about devices for people to be able to use then to entertain themselves or have classes or whatever. Would everybody have to have their own personal device then?
Well, some may have them, but don't have access to the broadband. I mean, there are that group of people, but I think for those who don't, and most I don't think would, because of the limited resources, that would be part of this discussion. I have the same thought there as well. You'd think we talked. I think that this would have to be part of it, having access, not just to the service, but to the devices. And I didn't think about training though. So you're right, that would have to be part of it too. Thank you.
All set, Representative Craven? For now? Okay, good. All right. So we're also going to hear from, again, next from Rick Erb.
Good afternoon, Senator Claxton, Representative Meyer, members of the committee. My name is Rick Erb. I'm with Maine Healthcare Association. We represent nursing homes and many of the PNMI Appendix Cs, and I'm here today to testify in favor of the Appendix C PNMI broadband. COVID-19 continues to shine the light on the connection between broadband and public health. Prior to the pandemic, telehealth was already growing in long-term care. Over the past year, many PNMI providers have utilized telehealth to provide healthcare services, education, and information to their residents. At the same time, we've seen successful outcomes in terms of access, quality, and value. Sustainable broadband is critical to continuing this healthcare delivery trend in the future. Technology also played a large role in addressing the psychosocial needs of residents as facilities were forced to limit visitors and families sought new ways to connect with their loved ones. As proposed in the bill, we fully support providing no-cost broadband access to these residents for their medical, educational, and recreational purposes. Approximately 70% of PNMI residents are supported by MaineCare, and as such, it seems appropriate for the state to leverage assets to secure funding to solve the broadband challenge for these residents. It is a goal that is well suited for a public-private partnership and in lockstep with the administration's broader commitment to the issues for all Mainers. Whether it is for telehealth or FaceTiming with grandchildren, access to broadband will support person-centered care and quality of life for our PNMI residents. MHCA and its PNMI members would be pleased to participate in any effort by the Department of Health and Human Services to address this important issue. Thank you.
Thank you. Are there any questions for Mr. Erb? Yes, Representative Zager.
Thank you, Mr. Chair. Mr. Erb, really appreciate your like decathlon of testimony today. I guess I'm wondering if I could just pose the question that just came up when Representative McCray just introduced the bill. Do the PNMIs that you represent already have broadband, and if so, how reasonable is it for them to use that access and expand that? You may not know that off the top of your head, but that's a question that I have. Thought you might have some insights.
For those that do have access to broadband now, I would be quite certain that the residents also have access to it. But frankly, I have not asked. I didn't participate in drafting this bill or preparing it, so I would need to get more information. One thing that was sort of a telling event for us was to early in the pandemic, we received grant money to purchase tablets in the nursing homes. But because the source of the funding was exclusive to nursing homes, we could not purchase them for our PNMI members. It was a federal requirement. There was no way around it. But I thought at the time it was unfortunate that they were excluded. If we find that there is the ability to bring broadband into facilities where they do not already have it, we would be very happy to participate in that. It would have been a big help during pandemic. I just need to find out more, but thank you for asking.
I realize that might be a better thing for the work session. I appreciate your willingness to explore that.
Representative Perry.
Yeah, just to expand on that a little bit is
if they have enough broadband to have several people using it at the same time. And the limitations that go with that. I did home visits with assisted livings, and there was a couple of assisted livings in the real rural areas that I couldn't even use my hotspot on my phone because there was no connection. So I'd love to know how many don't now, because these have managed to get Wi-Fi.
We can survey our members on that.
Okay. Are there other questions of Mr. Erb? All right, then we'll go to Simone Malin. Welcome.
Good afternoon, Senator Claxton, Representative Meyer, and esteemed members of Health and Human Services Committee. My name is Simone Mallon. I'm the Executive Director of the Consumer Council System.
We're having a hard time hearing you. Can you get closer to your mic?
Yep. Is this better?
That's better.
Okay. So I'm Simone Mallon. I'm the Executive Director of the Consumer Council System of Maine. And as you may remember from our orientation, we represent folks who live with mental health challenges in public policy matters, myself included. And never did I think in my life I would be asking a legislator for a broadband bill, because it's not my area of expertise at all. But what is my area of expertise is asking my fellow peers what's going on in your world, and what is your struggle.
I think you need to lean a little bit to your right. There we go.
I'm coming in closer.
There we go.
Okay, so, you know, I'm not a broadband expert and never thought I'd be doing this, but because we've been talking to peers on the ground, out in the world, in the community, all through the pandemic, we have really learned about the inequity and the challenges that many folks have around accessing broadband. We spent a lot of time in the beginning of COVID working with the mental health peer centers and trying to help educate other fellow consumers on how to use Zoom and all these things technology related, if they were blessed enough to have them. And what we found out by doing forums out in the community is we had members who were living in PNMIs that did not have access to internet, and they live in a populated area that I don't think would be considered rural at all. And there was access for staff, but not for the residents. So we heard this several times and felt like this is we knew there would be lots of broadband bills given the pandemic and what that has taught us all. But we didn't know that people would think about people, especially in PNMIs, which are thousands of Mainers when you include nursing homes, because of the limited financial picture that they have, they're allowed to have in a PNMI or a nursing home. And so that's why we have brought this issue forward and we feel passionate about. And there are many facilities that have broadband access for their residents. My husband's been in and out of nursing homes several times. We've always had access to Wi-Fi. The issue is that it's not consistent across the state. And I get if there's no broadband access, that is a real barrier. But for those especially that do have access, then we really want to make sure that all are providing free Wi-Fi as a utility that they're getting paid for, to really make sure people have that access for not only telehealth, but
30 seconds, Simone.
Thank you. For spiritual needs, one of the things about teaching one of my board members about Zoom finally was that he was able to join his church community online. And so these pieces are critically important, and we just want to make sure that there is equity across the board for all folks to have access to broadband. Thank you.
Thank you for your testimony. Does Representative Perry have a question? It's that button again. Okay, I don't see any questions, but thank you for being here, Ms. Malin.
Thank you for your time.
And that'll bring us to Tierra LaPierre.
Thank you. Good afternoon, Senator Claxton, Representative Meyer, and other members of the Committee on Health and Human Services.
My name is Tiara Lapierre, and I'm a Master's of Social Work student and a member of the NASW Maine Policy Committee. Today, I'm here to represent the NASW Maine, the professional organization that advocates for the 5,000 licensed social workers in Maine and their clients. We testify in support of Representative McCrait's bill to increase broadband access in private non-medical institutions. We believe that persons living in residential care or assisted living need access and equipment necessary to meet their educational, medical, work, and recreational needs. This bill requires DHHS to collaborate with non-medical institutions to strategize and develop a plan to meet those needs. Just like universal electrification in the 1950s, universal connectivity to the internet will address inequities and build a strong future for all communities and persons in Maine. During the past year, we have experienced an unprecedented increase in telehealth, work from home, and online learning, which has magnified our awareness of the imperfections in our internet connectivity. A Mission Broadband survey in August of 2020 indicated that 47% of Maine respondents believed that their internet needs were not being met. This is unacceptable for health, education, and employment opportunities for all Mainers. NASW Maine believes that Maine needs multiple financial streams and intense community collaboration on this issue to address these inequities in access, affordability, knowledge, and skills. Monies and collaboration between the federal government, state government, internet service providers, and communities are needed to support world-class internet for Maine. We urge you to support LD 1148. And just as a student, I would like to mention this conversation we've had about just the disparities that are so different from institution to institution across Maine. I've been working on a tele-wellness project to work towards health goals with older adults. And I was working with an individual who was part of a couple living in an independent living facility. And he and his wife could log in together, but if they had to separate onto different tablets or computers or whatnot to go over their individual goals with students, their internet would shut down because they couldn't both be online at the same time. And so this is an issue that I've witnessed as a student as well. Anyhow, thank you for your time, and that's all from me.
Thank you for your testimony. Are there any questions? I don't see any for right now. I don't also see anybody else who's testifying for this bill or anybody testifying against. That'll bring us to Mr. Sanborn, who's here to testify neither for nor against.
Thank you.
Welcome.
Thank you, Senator Claxton, Representative Meyer, members of the committee. My name is Ben Sanborn. I'm the Executive Director and Counsel for Telecommunications Association of Maine. We represent the rural broadband providers in the state. And the reason that we're testifying, and I've submitted some written testimony as well, it's very brief. We support these sorts of discussions with regard to how do we get these services out to the people who need them. And one thing that we've been frustrated with in the past is that groups have gone off and had a discussion about how do we meet the needs of our constituency and then come back and say, here, we need you, the providers, to do this. And we look at it and say, that's a great idea, but it won't work. And here's why. And so we've been trying to get a little more proactive to try and be at the front end of these discussions, because we think it's important for these to have real workable end results. And we want to be a part of the process that helps make sure that these end results do succeed. And so to that end, if there is a group that is being formed or discussions being had with regard to how do we, for example, make sure that the locations have sufficient broadband access and determine are there programs that exist for some providers who might be able to help make these more affordable for the institutions or assist the folks who are within the institutions to have access to services, we would love to be a part of the conversation. And so that's essentially all we're here for. We're neither for nor against the bill, but if it does move forward, we do hope that you consider including the broadband providers up front so that we can really make sure that a good workable solution emerges. And with that, I'm happy to answer any questions.
Thank you, Mr. Sanborn. Thank you for your testimony. We're pretty good at rounding up stakeholders, so we'll you have a large stake in this work, so we'll try and encourage that kind of behavior. Are there any questions for Mr. Sanborn? I don't see any, but we appreciate your taking the time to be here. and to share that perspective.
Thank you.
And as we get, that'll conclude the public hearing portion for consideration of LD 1148. Are there any questions that we'd like to direct to Anna for the work session? I don't see any at this point. Yes, Representative Perry?
I'm sorry.
Hoshi with the button problems?
Right. I do have a question, and I don't know in terms of the involvement of Connect Maine in areas that they look at as the greatest needs in the state, because I know they work with statewide broadband help.
Okay, thank you. Any other questions? All right, anything you need from us, Ms. Brom? Any clarification, any next steps?
I do actually have an amendment and a letter I would like to share with you, if you don't mind.
Before they do, I want to correct, if Mr. Erb is still listening, that it really was an octathlon, not a decathlon.
Is that a thing?
Was today.
I am just going to share my screen. This is LD 121, which is it's not quite what I wanted to bring up, but it will do. I was going to bring up the amendment first, if I can do that. Can you see the amendment at all? What are you looking at? Are you looking at a letter or are you looking at a bill?
Looks like a bill, LD 121.
Excellent. Okay. So this is an act to require a background check for high-risk healthcare providers under the Main Care program. This has a really small amendment to it because this is the bill. You have to cast your mind back a little bit. This is the bill that requires fingerprint-based background checks for high-risk providers, which are defined in federal law, federal regulations, I should say. And there was one amendment change to it, which was that this bill was originally drafted to say that the provider, the background check information may be used by the department for the purpose of screening the provider applicant. And you made that stronger to say that it is to be used. Shall didn't work in the sentence. I know it sounds like it should, but this is just a different way of saying shall. But what I really, so that's the amendment, which was small. But in addition to that, it also has a public records exception. So I just wanted to let you know that I have written that letter. I'll send it out to you. You'll find that in your inboxes shortly. The Judiciary Committee next Wednesday on the 13th at 1 o'clock will be doing the public records exceptions for this bill and for the mortality review panel that is included in the budget in LD 716. I know I've mentioned that had been scheduled already, but I don't know if I told the entire committee that that would be happening. It doesn't require the entire committee to go, but it does require some chairs. And in this case, this is a committee bill. So I would expect that somebody from the department will probably be there for this one as well. And actually probably for the other one, since it was the bill is not a committee, it is not a department bill, but the budget was. So I just wanted to let you know that that amendment was drafted and that that letter was ready to go and that you would see that letter in your inbox quite soon.
Very good. Any other questions? Any other things to bring up?
Nope.
Before we quit, I do want to recognize that Carrie has changed a bunch of things as we go along. Now the LD we're considering is posted. That's been very helpful and I appreciate that. And I'm not sure you all see it, but we get regular communication from her during the course of the hearings about who's up next, who's for, who's against, and it's happening seamlessly, and we're grateful for that. So we're lucky that you're here and lucky that that you're so capable. So thank you.
Thank you, Senator Claxton.
Let's see if we can make Carrie blush afternoon. So I don't see anything else to be touched on right now. That takes us to a 9 o'clock start tomorrow morning, which is a combination of public hearing followed by work session later in the day. and we'll go there and see you around 9 o'clock tomorrow if everybody's in favor of adjourning.